Good morning and welcome. Thank you so much for joining for our exciting launch of Paediatrics 2040. Absolutely delighted to have you here. I wish we could be face to face, but nevertheless, we're here, we're online, and we're really pleased that you're with us. If you haven't already, please check out the microsite paediatrics2040.rcpch.ac.uk. So, good morning. My name's Hannah Jacob. I'm the outgoing chair of the RCPCH Trainee Committee and the co-chair of Paediatrics 2040. I also co-led the innovation workstream with Dr. Damian Roland, who we're going to hear from a little bit later on. It's been so exciting to be a part of this project. We're going to hear from lots of the people who've been involved today, but I think the opportunity to look up from the page and move beyond firefighting has been so exciting. And ultimately, this is the future that we'll be working in. I think one of the most exciting things about this project is that actually it's involved a huge number of people, but also paediatricians and future paediatricians from an enormous range of backgrounds. We've had children and young people being involved, and we're going to hear from them a little bit later on, medical students, foundation doctors, paediatric trainees and fellows, as well as consultants, both clinical and academic. Just in terms of housekeeping, if you do lose your connection, you can rejoin using the same link. And if your Wi-Fi completely packs up, the event is going to be recorded and you'll be able to watch it back on the website afterwards. If you have any problems with your audio visual, please put them in the Q&A box and the events team will keep an eye on that throughout the course of the sessions. We're going to be taking questions throughout, so please submit any questions you do have in that Q&A box on your toolbar. We're really keen to have interaction. If your question is specifically directed to one person, please make that clear in your question, and otherwise we'll put them to the panel. So, what we're doing today, we're actually going to have the events split up into 4 sessions. We're going to hear from the lead of each of the work streams as part of Paediatric 2040. So that's from data, from innovation, from models of care and working lives. And they're going to tell us a little bit about the work they did and the conclusions they reached. And as I mentioned, there'll be a Q&A for each session. We're also very excited to be joined by some of our new college officers who we're going to hear from a little bit later on. And then we're going to end the day hearing from our President-elect, Dr. Camilla Kingdon, and our Chief Executive, Jo Revill, about the college in terms of the future, particularly thinking beyond COVID-19. So, without further ado, let's get started. We're shortly going to be hearing from our keynote speakers for the first session, Professor Russell Viner, who's led this project during his college presidency, and also from Professor Helen Stokes Lampard, who's chair of the Academy of Medical Royal Colleges. But before that, I think it's entirely fitting that we open this event hearing from children and young people. There have been almost 900 involved in this project from around the UK. And so I'm going to hand over to Anwin, Bryn, Demi, Izzy, Noor and Toby to outline their vision for the future. They're not here live because they're either at school or homeschooling, but they've put together this video for us to give us an idea of their vision for the future.
Good morning and welcome to the launch event of Paediatrics 2040. My name is Toby and I'm part of &Us, a group that has been analysing collected voice data and listening to the changes that children and young people would like to see in paediatrics in the next 20 years. First of all though, we would like to take a moment to thank all paediatricians for the work that they do already, for which we are all grateful. The top issues that we think are important to bring to light are working with us and prioritising key skills, children and young people's mental health and mental health in a crisis. Any questions that you may have can be answered on the Voice Matters section of the microsite. I will now pass off to Anwin on working with us.
Hi, my name is Anwin, and as part of the Paediatrics 2040 project, RCPCH&Us worked to establish the main features of the Working With Us that children and young people said was most important to them. Paediatricians involved in the care of children and young people should continue to be respectful, kind, supportive and friendly, empathetic, understanding and actively listen, open-minded and to be aware of different backgrounds and experiences of young people. Children and young people across the nation said that the worst doctor is someone who does not respect their feelings that they're going through with your health. We want doctors to be accepting and have a non-judgmental approach whilst continuing to be professional, positive and have a sense of humour. I will now pass you on to Izzy, who will talk more about what children and young people have said they want to see.
Hi, I'm Izzy. I will be continuing to talk about working with us. Keep doctors human, said young people in England. How then do they propose to enact this? Some ideas put forward by young people across the UK included finding new ways for paediatricians to show listening to explain things, a choice of what gender paediatrician they were seen by, and support for paediatricians with topics new to them, such as LGBTQ+ issues and eating disorders. Young people feel that the best doctors are those who can listen to children and young people, and they want to ensure that the right people choose paediatrics and love their occupation in the future. Whilst it's inevitable that technology will be even more prevalent in the year 2040, young people still see a place for face-to-face appointments with real human paediatricians. Overall, the message from young people is for paediatricians to keep listening and respecting children and young people, to be open-minded and trust them, and to treat them as people, not just as a condition. Many other ideas and further detail and statistics on the topic can be found on the Paediatrics 2040 Voice Matters microsite under Working With Us. I will now pass on to Noor.
Hi, my name is Nora and I'm going to be talking about mental health. As young people involved in Paediatrics 2040 sessions, we believe a focus on mental health should be a priority. Mental health problems affect around 1 in 9 children, although in 2020 this number increased to 1 in 6 children. As per our mental health infographic, we have 4 main focuses. 1. Removing the stigma around mental health. This will take time, effort, lots of education, and a change in attitude. As mental health can affect physical health, and physical health can affect mental health, we want every paediatrician in 2040 to have had mental health training so that both physical and mental health care can be integrated. This way, young people will be more inclined to open up, and so ultimately, the stigma around this will be reduced. 2. Making sure people feel comfortable asking for support. We want mental health support to be accessible at all times by using technology and social media so that support is there at the press of a button. 3. Supporting good mental health and well-being. This should be done through encouraging sport, healthy eating, and public health campaigns discussing issues such as addiction, bullying, and eating disorders. And 4. Ensuring young people have opportunities to deal with their mental health both at school and at home. We believe that having a well-being clinic at schools where one-to-one discussions and follow-up sessions are easily accessible will give young people more opportunities to address their concerns. I will now pass on to Demi.
Hi, I'm Damian. I'm going to be talking to you about mental health and the issues that can occur within a crisis, how we can improve the mental health services during tough times. Children and young people involved in Paediatrics 2040 sessions have talked about the impact of COVID-19 on their mental health. They stated that things to remember are to ensure children and young people don't feel forgotten about, to provide health promotion messaging, to ensure confidentiality during home appointments is there. What does the ideal mental health service look like in 2040? We have discovered that COVID-19 has impacted children and young people's mental health greatly, but from a bad situation of a global crisis, positive changes can be made. We spoke to young people but got shocking feedback that stated in a crisis like COVID-19, how could they complain and suffer when there's people who are worse off? This just shows how big of an impact a crisis can affect young people and their opinions of finding help. This is a reason that things need to change and shows that there's still such a stigma. We spoke to children and young people all across the UK. These are some of their quotes. It's a pandemic, so I can't talk about my mental health when all that is going on. They should have a range of options so young people get anxious on a phone and some young people get anxious meeting the professional in person, so they need both options. I would rather wait it out than go for help, so not to burden the NHS. Make sure there are opportunities for me to do things to support my own mental health. This shows that young people feel as if they're a burden or get in the way or aren't as important as other members of society and don't seek help when they need it most. For children and young people in a crisis, it can be isolating, and when COVID hit us, our health services adapted so quickly. But was that at a cost? With telephone appointments, that means there's no confidentiality at home. Can we fix it? Maybe if we all work together. We spoke to 57 young people that talked about COVID-19 and the future of healthcare. They said important areas to focus on within the Paediatrics 2040 workstreams are supporting mental health services to adapt quickly to provide online or phone-based support that meets the needs of children and young people using them. Help staff with new normal, with a strong focus on the well-being, resilience and mental health support for patients, families and staff. Create new ways of working that support confidentiality in the home so that children and young people can talk about private matters with doctors. Listen and hear young people. Give us options. So as you already know, you're all great doctors. But these 4 ideas are to help make the system better, which in turn make you greater. Thank you for listening. I'll now pass you on to Bryn.
Hi, my name is Bryn, and I'm going to conclude today's speeches. You've heard a lot of ways in which children and young people would like to see paediatric care changed or continued in 2040. Today's topics have highlighted when working with us, that doctors should continue to be compassionate, and they need to make sure the patient understands everything he or she is saying so that they can feel involved in their care. We've also heard lots of ways in which mental health should be a priority in the future, and how children and young people would like doctors to know more about mental health and how to help their patients, not only with their medical condition, but with their mental health as well. Some ways that doctors can help their patients through mental health problems is by showing them that they're not alone, and to provide support and access to mental health services. As COVID-19 has had such an impact on children and young people's mental health, we should see this as an opportunity to change things for the better. I think the single most important factor for the future has to be mental health. Not only can mental health take a massive toll on the child or young person, but the effects on the medical condition also make it, in my eyes, the most important factor that doctors should consider and understand more by 2040. Finally, I have to say it's easy for us to say doctors need to be doing these things by 2040, so on and so forth. But we need to understand that doctors are already doing so much, and so these suggestions are not to fundamentally change them, but make them better. Thank you for listening to us today, and we hope you enjoy the rest of this event. Please visit the Voice Matters part of the microsite to find out more from children and young people.
Absolutely fantastic. I think that, as ever, the children and young people have said it better than any of us could and really provided their challenge to us for the future. I'm delighted now to hand over to Professor Russell Viner, who's going to give us the first of our keynote speeches. As you all know, he's the RCPCH president from 2018 until May of this year. And also the overall co-chair of Paediatrics 2040. Just a reminder that you can use the Q&A to pose questions that we'll put to him at the end of this session. Thanks very much, Russell.
Thank you, Hannah. And good morning, everybody. I hope you can hear me. We started this morning, as we started this project, with our trainees in the form of Hannah, our chair of trainees, as the co-chair of this project, and with children and young people at its heart. The future is coming, and that's what Paediatrics 2040 was about. The future is coming, and unless we imagine what that future might be, unless we dream about it, the future will happen to us in ways that we really don't like. So these kind of future visioning projects can feel self-indulgent. They can feel a bit unrealistic. 2040 is a very long way away. But I just wanted to repeat, unless we dream about the future, it will happen to us in ways we don't like. Hannah's already mentioned this. We spend a lot of our time looking at the very close future, very much in college, and I know that you do in your clinical services. We look at the problems around us, we look for fixes, we plan for the next 6 months, the next year, even the next 3 years. College is very good at that. But there's a problem with doing that, which means that we are focusing on the things we can see around us. We are focusing on the things that are wrong. We're looking down at our feet that are stuck in the mud. And the trouble is, if you walk along, you'll know this. If you walk along and look at your feet, you will fall over. You won't see those things that are coming, that are just not straight in front of you, but a little further away. Those rocks, those mountains, those trees that you walk into and you fall over. So we have to lift our eyes up a bit more. We have to look further out. We have to look out 20 years and try and look at not just what's going wrong around us, but what do we want to go right? How do we want that future to be? What is the best possible future for our children and young people and for our members, our paediatricians? Remember, the Royal College of Paediatrics and Child Health, we're the only college that isn't named after the doctors, but we're named after what our doctors do, paediatrics, but most importantly, after the children and young people that we serve. And very much this 2040 is about both of those things. I would say we called it Paediatrics 2040, not Child Health 2040. We did that for two specific reasons. Firstly, RCPCH doesn't own the whole of child health. Of course we don't. Children are hugely broad. And when we work in child health, we work with colleagues from primary care, across mental health, and across a whole range of other disciplines outside of medicine. But more importantly, we wanted this to be about our members as much as anything. Paediatricians are very good at saying, it's not about me, this is about the children. And we've said, actually, Paediatrics 2040 is a lot about you as well as the children. And that's very important. So this is about lifting up our eyes, not being unrealistic, but trying to get that look out to 20 years. We absolutely realize we can't see 20 years. We can have a look. We have this thing called the cone of uncertainty, which is something interesting that futurologists get interested in. If we look out into the future, if we look straight ahead, that's an assumption essentially that the future will be largely like it is today. If we lift our eyes up and we have a very, in a sense, positive or utopian view, we can see how things will get better. And if we look down and look at the problems, we have a bit of a dystopian view about how things may get worse. And that cone, in a sense, is our vision of the future. Apologies, my phone spam is going. How annoying. But anyway, that's one thing we'll get rid of in the future, phone spam. So setting up the project was very important to us that it involved the whole college. We had Hannah, our chair of trainees, chairing the project with myself. And that's a statement that says the future actually is about the younger members of our college. Some of us in 20 years, hopefully, will be sipping cocktails with little umbrellas in them on a beach somewhere much of the time, hopefully. Our trainees will be quite senior consultants in 20 years' time. But we also included many of our medical students who will be working with us in 20 years' time. And we also included all the way through to our oldest consultants, who, of course, will be hopefully joining me drinking cocktails. We also had a very strong geographical spread across all the nations of the UK. And we also made sure that we had significant diversity. We have 5 work streams for State of Child Health. The children and young people form 1, and then 4 work streams for paediatricians. We had 10 commissioners in each. And for each of those work streams, there were medical students, foundation year doctors, trainees, consultants, retired consultants, etc. So really important that we had that spread. Okay, what were our 5 work streams? We organized them into 2 input and 2 output work streams. I know that sounds a bit processy, but the inputs were data and innovation. They told us what we think might be going on in 2040. The data work stream was co-led by myself and Steve Turner, our Officer for Scotland at the time, soon to be our registrar. And that was asking questions like, how many children and young people will there be in 2040? What will they suffer from? What's coming in terms of disease burden? And what's going? What's hot, what's not? Children and young people have told us very clearly mental health, we know that. And in one sense, the answers have been around for a while. It sounds funny in the middle of a pandemic to say infectious diseases are going away, but mostly they are as a cause of burden for children and young people. Burden is shifting to non-communicable diseases, long-term conditions, mental health, and particularly also shifting towards adolescents and young people. We're seeing a change in the burden of disease across childhood. It's concentrating in the under 1s, under 3s, and in adolescence. And that mid-childhood bit is now becoming the healthiest time of life. And certainly by 2040, it will very much be. So we're going to have to respond to that. The second bit was around innovations. Now, I know the Academy, Royal Medical Colleges, and the government and others have done a lot of work looking at this. AI, artificial intelligence, is coming. Genomics, the digital world. COVID has taught us a lot about innovation, but there's also a huge amount more to come. We think much of this will make our practice dramatically different. I'm a diabetologist by background. Last year, was it the year before? Maybe it was the year before. I started to see my first patients on smart insulin pumps, AI pumps. I also started to see my first patients who are hacking their insulin pumps, hacking their continuous glucose sensors, and running AI algorithms on their phones, hacking the pumps and using this crowdsourced algorithm to control their insulin pumps and turn the insulin up and down, outside the governance of the NHS, which is a huge challenge for us. The future is here, it's just unevenly distributed. So there is AI happening all over the place, and we're going to have to work out, actually, what does a diabetologist do if the patient is using a smart AI pump? My job of saying, turn the insulin up, turning the insulin down, that's gone. So we're going to have to actually understand how that impacts on us, but also be very careful that these innovations don't increase the inequalities. Because of course, you won't be surprised, it's wealthy families that are doing this, and our poorer families can get left behind. The second group of work streams were saying, okay, given the innovation, given the data, the first work stream is models of care, which is asking how are paediatricians going to be working? Are they going to be working in hospitals? Are they going to be working in the community? Are they going to be working together? Are they going to be working closer to primary care, further away from it? You won't be surprised. The answer is absolutely lies around better integration, focusing the models of care on what patients need and what they see. And what that tells us is integration across primary and secondary care, working with our primary care colleagues, integration of mental and physical health. That is the absolute key one, really key. And our young people hammer that home to us every time they speak, like they did this morning, in a whole range of different ways. The last work stream, perhaps possibly most important to the college, working lives. Firstly, how do we train for this future? And I think really important to me, what does a mid-21st century college look like? It doesn't look like old boys and port. It doesn't look like anything probably we are quite now, though hopefully we're getting there. But what does a mid-21st century college do to support its members through their long working lives, to support children and young people and improve the quality of life of our members? So hugely exciting for me, and I hope hugely exciting for you. I'm going to finish now and say I think it's been extraordinary the way all parts of the college have come together to pull this together. Really amazing. I'd like to particularly thank Alison Firth, who has been our administrator leader on this role, on this project. She's been extraordinary. Alison, thank you. And thank you to Rob Akunu and the whole Policy External Affairs Division for pulling this together, and all other parts of the college, and Jo Revill, our Chief Exec, for supporting it, and Camilla, our new president, for really supporting it as well. So our next speaker, I might hand straight over to, if that's all right, Hannah, because of time. I'm hugely pleased that we have Helen Stokes Lampard. And in many ways, it's a nice little segue there. I said one of the things about this is finding out for us what a mid-21st century college is, and it's not old boys and port. And actually, I think in lots of ways, Helen exemplifies. Helen's chair of the Academy of Medical Royal Colleges, which is the umbrella group for colleges such as us. So she's an incredibly important, one of the great leaders of the medical profession in this country. And I think Helen, in her own person and the way she operates, exemplifies much about what 21st century medicine is about. Helen, over to you. Thank you.
Gosh, thank you, Russell, and thank you, Hannah. And I want to say thank you to the absolutely brilliant team at RCPCH. It's really wonderful to be here, but as others have said, it's a little peculiar to be doing this remotely. I relish face-to-face interaction is what I'm all about, but we'll do as best we can. So good morning, everyone. I'm Helen Stokes Lampard, as Russell has said. I'm actually a GP by profession. I'm based in Lichfield in Staffordshire, and some of you will pick up the Welsh accent, so I brought a few daffodils along as it's St David's Day on Monday. But I still work at the front line, albeit part-time due to my other commitments. And like Russell, I'm also an academic. I'm technically a professor of GP education at the University of Birmingham, but I'm seconded away from that right now. But I wear another hat. I'm chair of the board of the National Academy for Social Prescribing. And that's a new charity which seeks to explain what social prescribing is, making a noise about a movement that's supported by the NHS in England. And that is the first major healthcare system in the world to support social prescribing on such a scale. And this Social Prescribing Academy seeks to generate and disseminate evidence about what works and build partnerships with organisations that deliver social prescribing to ensure it can become mainstream for everyone. So ultimately, we want to ensure that everyone, irrespective of age or any other characteristic, can access the support they need to help them live their best life, whatever their medical needs are. And our vision there is a social revolution in healthcare. But Russell invited me to speak to you because I am chair of the Academy of Medical Royal Colleges, this body that brings together every different medical discipline to achieve consensus on standards of care, education, and career progression for all doctors in the UK and Ireland. And we speak out for doctors and patients on issues affecting us all. So we're in this new COVID-tinged world, a world where inequity and the social determinants of health have a very tangible and immediate impact on survival from infection. We are in truly crazy and unprecedented days. So before I go on to the 2040 report and its implications, I thought I'd share with you first what the Academy of Medical Royal College's approach to the future is, and I think you'll see a lot of synergy. So I'm going to offer you sustainability as an umbrella that we can use to bring all these challenges together. So 3 pillars of sustainability. First, the sustainability of our planet and our responsibility as healthcare professionals, as well as our responsibility as citizens, the green agenda, if you like. And let's face it, environmental sustainability is a profoundly bigger challenge than COVID-19 is to our long-term well-being. And actually, we all know that we can survive by travelling far less. And we owe it to our young people to be more active in this space, and it is their planet after all. Secondly, sustainability of medical careers. Now, traditionally at the Academy, we focused on medical students through to mid-career doctors. But actually now we're actively widening this focus to consider people from their earliest thoughts to entry to any part of medicine, through to our colleagues who are long retired, recognising they have so much to give back. So how do we better nurture our colleagues? How do we make training and professional careers rewarding and fitting for the times in which we live? Training with eyes to the future and respecting but not clinging to the past. We have to be more aware of the needs of those younger people brought up in a different generation from those of us who tend to be leaders and see the world through their eyes. Our future training must ensure we're developing doctors who completely understand the need to be patient-centred, who truly understand the social determinants of health, the challenges of health inequalities and digital exclusion. We need doctors that understand their role as leaders in this new landscape, and that therefore they must understand how the whole system works. People who have a great generalist background of their chosen discipline, irrespective of subsequent subspecialisms. Doctors who are equipped to supervise and support teams of other health and care professionals to ensure that our patients get the complete care package they need, one that fits them as a whole person. Future doctors need to be exceptionally good communicators, translators if you like. If we can all communicate better with our patients and their carers and work with them, if people feel valued, included and part of the healthcare process, irrespective of their age, they get so much more out of their care, and in turn, they become our greatest allies to fight for the NHS for the future. We also must ensure we have sufficient numbers of doctors in every part of the country. We all know the challenges of under-doctored areas, and our current structures celebrate and encourage super specialism in highly specialised centres. So we also need to incentivise excellence in generalist clinical practice and incentivise working in the less glamorous areas. And so my third sustainability banner is the sustainability of our amazing NHS in all 4 nations of the UK. What will ensure that comprehensive, state-funded, universal healthcare can endure for another 70 years? And I believe we need to rethink healthcare, or at the very least reframe it. And what I mean is we start with the citizen, the person in their own social and domestic situation, empowering them to live their best, their healthiest and their most rewarding life. I'm not going to reiterate the social determinants of health again, you get that. But having access to a good education, living in reasonable housing with people who care for you, based in an environment that supports healthy, sustainable living. So that's involving communities, local governments, employment, and all the factors that we know impact on health inequalities. And then when people need advice about basic health and well-being or care, they're informed, they know where to go and how. They're digitally supported and enabled with accurate, personalised information at their fingertips, or at least available locally to them. And then when there really are medical issues, the point at which we call people patients, healthcare entry points are clear, unambiguous, easy to navigate, joined up, and people remain considered as the whole person. And then, of course, when medical things are happening, serious things, the system responds to those. It communicates seamlessly within itself and with the patient, and it does what it needs to do, but always remembering the whole person. Paediatrics has always been so much better at this than many others of medicine, trust me on that. So the NHS and the care system doesn't treat people in parts for longer than it has to, and that is a summary of what I call rethinking medicine, starting with a person, not starting with institutions. And it's not radical, it's common sense, and I suspect that you get this, but it is flipping much of the way our current structures are set up. Structures that currently start with big hospitals and super specialities and work backwards from there. Now, there are myriad initiatives already trying to do this. Scotland have had realistic medicine. Wales have had prudent healthcare, and they're a great start to this. NHS England have invested heavily in personalised care, evidence-based interventions, over-medicalisation, getting it right first time. There are loads more. But ironically, they're doing those things in isolation. So rethinking medicine is my way of stating a vision. And Paediatrics 2040 is your way of stating a vision. And what a vision. Innovation, models of care, working lives. There are synergies with what I've just said. So innovation, using the advances that COVID has accelerated, building on them, an improved landscape for innovation and co-designing it with children and young people, ensuring that everyone can use and access it, not inadvertently further isolating some groups as we so often see in healthcare. Models of care, ensuring that children and their family are at the centre of the care we deliver, which fits beautifully with rethinking medicine approach for the whole of medicine. So ensuring communication is right for the patient. And the working lives of paediatricians and their colleagues, whether that's doctors in other branches of medicine or the other healthcare professional colleagues who will work alongside us to deliver care. Improved communication, collaboration and flexibility to ensure that healthcare professionals are ready and able to do the best possible job. They're fulfilled and engaged with the wider landscape. That's what a vision, and I congratulate all of you who've created it. I love it, I get it, and I commend it. But I'm going to wrap up by suggesting 3 things that we can and must prioritise if we are all to stop the health and care system falling over as a result of this pandemic. And the first is we must demonstrate clear, unambiguous clinical leadership. So that means us owning the issues, setting clear direction and leading by example. The second priority is to call out poor decisions, poor policies and poor practice. If something is wrong, if quality of care is being put at risk for the sake of political expediency or dogma, we must say so. And for those of us who have a regional or national voice, we must speak very clearly and, if required, very loudly, sometimes publicly, but often not. Now, goodness knows what further sloganised messages or directives from government and the media will be landed on the public in the coming weeks. We need to remain the voices of clarity, consistency and confidence. And finally, and perhaps the most exciting opportunity ahead, is to reset our patients and their carers' relationship with the healthcare system. So I believe we have a once-in-a-generation opportunity to have an honest conversation about the care that doctors should and should not be delivering, where that care should take place, and what our patients should and should not reasonably expect. So we start the medical journey with the patient, not with institutions, rethinking medicine in a practical, accessible way. And Paediatrics 2040 is that way ahead. Our role as doctors and healthcare professionals, whatever level of leadership we believe we occupy, is we must do everything we can to ensure the apocalyptic predictions do not happen. We must be part of the solutions, not amplifying problems. After a truly grim year, we're also entering a time of hope, where despite the media rhetoric and political squabbling that drags us down, there are bright gems sparkling with positivity, promise for the future. We are truly privileged to be doctors, and together with our empowered patients, our young people, we can achieve amazing things. Thank you all so much, and really well done again on this report. Back to you, Hannah.
Thank you so much, Helen. I think what a powerful end to a really, really absolutely excellent session. Thank you, and thank you to Russell too. So we're going to move to the question and answers. Just a reminder that you can use the toolbar at the bottom of your screen to submit questions. So we've had a few questions come in today. The first, Russell, is to you around how we get political buy-in for longer term planning and investment when so often politicians are focused on shorter term outputs and results.
Really good question. The political cycle is far too short and it's very difficult to get that longer term buy-in. Look, I accept that. And that's something we can't change quickly. One of the things we've focused on very much has been getting politicians to recognise the importance of investing in children and young people's health. I've had a view very strongly during my presidency that the best way we can improve the working lives of our members, the quality of life, best way we can improve children's services and get more money into children's services is to convince politicians of the importance of investing in children more broadly. And actually COVID-19 gives us another opportunity to do that. I think that there is a real head of steam coming to make sure that we invest in mitigating the impacts of the pandemic on our children and young people. We're already starting to see the government putting money into catch-up education. And I think we should be, we already are, the college is very much in there arguing that the focus on children and young people's mental health, stopping the short-term harms becoming scarring for a generation is going to be key. So I don't have an easy answer, but we're still in there working.
Thank you, Russell. I'd also like, I should have done this already, to introduce Emma Sparrow, who's the RCPCH Children and Young People's Engagement Manager, and also Emma Hoskin, who the RCPCH Engagement and Participation Youth Worker. So they're both available as well, taking questions on behalf of the children and young people. One question I wanted to ask you both was about whether you have any tips. The children and young people very clearly laid down the gauntlet for us as paediatricians around improving services and improving training and accessibility. And I wondered if you had any practical tips from the children and young people about ways in which we could actually make that a reality.
Are you talking? You're talking to?
This is a question to the Emmas.
Oh, the Emmas.
Shall I go first, Emma? Okay, I think that when working with the young people, that they kind of had three things that they were really kind of passionate about. Firstly, that so many paediatricians are already showing kind of kindness, friendliness, supportiveness, so to continue to do what you're doing. And one of their asks, I think, is to just inbuild kind of normal discussions around mental health and mental well-being, just a simple kind of how are you doing, how are you coping, and just an interest, so that it's not a big kind of massive conversation or assessment, but that every time you meet them that you're building up a picture about how they're feeling. Also, they want to kind of think about confidentiality when doing home appointments, because some of those questions about how are you doing might be a bit difficult for some young people to answer if there's other people in the room. I think one of the things that we really urge you to do is to go onto the microsite and read what children and young people have said, and print out their wonderful infographics, take them to team meetings, share them with colleagues, or when you're having one-to-one discussions with your practice supervisor, so that you can kind of start to think about kind of how you can kind of put this into practice. And then I think going forward, I think that Russell and Helen have really summed it up, as have the young people, about this kind of integrated support around physical health and mental health. And if we can provide ways in which we can normalise those conversations, we can understand the relationship between physical health and mental health, and that services work together, that's how children and young people feel that the next 20 years will be kind of better than they are right now.
Thank you, Emma. A question for you, Helen. A couple of people have talked about your reference to social prescribing, and particularly thinking for us as paediatricians about how much you socially prescribe for a child versus how much you socially prescribe for parents and for families more generally, accepting that clearly they're inordinately intertwined. I wonder if you have any thoughts about that.
Thanks, Hannah. So look, so for those of you who are not familiar with the term social prescribing, or have perhaps got an odd view of it, social prescribing is essentially helping people to find resources and support for all the stuff the NHS doesn't do that improves your health and well-being. So a social prescription will typically recognise there is a problem that, that is not physical or mental health related, but is much more related to the social elements of somebody's life. So it's enabling you to live your best possible life. And so it can be applied to anyone of any age with any background problems or any situation. But it's a clunky term, which I think gives people odd views at times, but we're stuck with the term. Social prescribing is what it's called. Currently, the NHS in England has invested in putting social prescribing link workers into general practices, and these are being gradually rolled out. So typically a GP will have an encounter with a patient or their carer and recognise that there are issues. It may be they need advice and guidance or support. It may be financial advice, but it also may be that they are sad and missing out on something. They have no sparkle, they have no joy in life, and they may not have they may not be clinically depressed, but they may not be seeing the good things in life. And so a social prescriber or link worker will help them to unlock those bits of their lives. The idea in due course that this is rolled out far more widely. And I mean, paediatricians, also a lot of occupational therapists and huge swathes of clinicians have done this historically. I mean, I always say that some of the best social prescribers I know are hairdressers, priests and bartenders, people who truly have an insight into the human condition and can advise and recommend. My hairdresser is marvellous at that. She sort of chats to people and draws them out. And in fact, I recommended that she become a Samaritan, which she's done, and she's now training as a counsellor. But these skills about this genuine interest in people are there. The obvious expansion is for a social prescribing link worker to go into care of the elderly medicine, to go into paediatrics and child health, and to go into mental health care. Huge swathes of medicine are clamouring for this because they can see the frustration we have as clinicians that we can't do everything for our patients. But once we identify needs, what we want is to be able to pass people on. So the next logical step for the NHS is bringing it, is putting it much more widely, but we need some evidence of proof of benefit. We need people to feed back about it. but recognising that people do not exist in isolation. I've seen some of the questions have talked about whole family approach. Absolutely. So many of these things are interdependencies. I mean, we've always said about people and their carers, but with children and young people particularly, it's the whole household approach that can be required. Now, that's quite daunting. This is incredibly complex social intervention. So with Russell and I, with our more academic hats on, actually measuring and assessing that and providing scientific valid evidence is hard. But the scientific community sometimes adopts a slightly snooty paradigm approach that, oh, well, we can only do it in terms of a randomized controlled trial, double-blinded. Well, that's entirely inappropriate for complex social intervention with perhaps 100 different variables in just one encounter or pathway. So we as healthcare professionals need to take a step back, learn a bit of humility and learn from our colleagues in the social sciences, but also open ourselves up to the possibilities. And we then in turn need to lobby for what we believe is genuinely right for our patients and their families. So I'm sorry, a bit of a wordy answer, but I tried to cover quite a few of the questions that were in the chat.
Thank you, Helen. I just want to quickly come to Emma, who also, Emma Sparrow, who's just going to mention on the social prescribing as well from a children and young people's point of view.
Yeah, so the Association of Young People's Health is part of the Voluntary Sector Alliance and that they coordinate, produced in the summer last year 10 top tips about youth social prescribing, and they've also got a resource on their website which looks into how this can really make a huge difference for children and young people. So I'll post the link into the answer on the Q&A, and then everyone can have a look at that as well. But the Association of Young People's Health and also ourselves have got quite a few different resources, but they've definitely got some stuff on social prescribing that I think will be of interest.
Thank you. A question to all of you, and we've got only a couple of minutes left, but this is a question that's been voted up and up the list repeatedly, and I don't think any of you will be surprised to hear. So the children and young people spoke very clearly and eloquently about the need to integrate physical and mental health, and lots of people saying that they felt that actually in the course of their training that they felt underprepared and under-trained to provide that service. I wonder if you guys have any insights in terms of ways that we can address that, and your vision for the future in terms of improving our ability to support those children and young people in integrating physical and their mental health.
Shall I start, Hannah? Absolutely. Interestingly, I think the college is hugely focused on this. This has been a focus of mine since I came into this role, but I think very much over the last 3 years and longer, we have very much recognised the importance of improving the support we provide and the training we give to paediatricians around mental health. And in fact, one of the things we did just this week at our college executive was invest more in how we do that. These things are not easy. One of the problems is the structures of the system separate mental and physical health. There are different commissioning, there are different hospital systems, and actually we need to challenge it at all levels. We need to support people by getting better training, both within paediatrics, but also exposure to mental health services. At an advocacy level, we need to, and we are campaigning for potentially different models of care. There have been models in Australia and America for quite a long time where paediatricians are much more involved in mental health services, particularly for adolescents. My own background is in adolescent health, which is exactly at that interface of physical and mental health. We also need to change commissioning models within the NHS, because that's part of the problem. But there's no easy answer. There are a number of online resources we already have available, but I think the key thing is listening to the children and young people who, there's an incredibly clear message, and we heard it again this morning. They don't see these things as different in their lives. And this is the great challenge of the next generation. Thank you.
Shall I pop in next then? So, obviously I completely agree with what Russell has said, and just perhaps to build on a few parts of it. So this goes back to what both the paediatrics vision and what the Academy's vision for rethinking is all about, is putting the patient firmly at the centre. Historically, the way we train our medical students and doctors is in quite a siloed way. We teach them in body parts. Now, when you're learning the scientific underpinning of medicine, that's really important. But when it comes to the delivery of clinical care, recognising that all these different parts of somebody's life are interdependent is so hugely important. And I'm very struck by, our Western model of medical care has been hugely powerful, the biomedical model. But actually the Eastern approach to health and care, which has always started with the totality of the person and not their body part, has a lot to teach us. And this is what I talk about, humility and learning from others and different ways of thinking. And if we truly do embed this approach to looking at everything that's going on in one go, whilst it can feel overwhelming as a clinician to think about all the various bits, obviously we then need to zoom down in the bits that we can fix at any one time. It will genuinely help us. And that needs to be reflected in our undergraduate teaching of medicine and indeed other care disciplines as well. So giving people that exposure to the whole patient, the real exposure to complex cases from the outset, not just focusing on very narrow. This is a completely average person who has diabetes, as opposed to this is a normal person who has diabetes, who lives in poor housing, who has these genetic influences, whose mother is depressed. And these kind of things will help people get more confident in dealing with that complexity, because it can feel very overwhelming for healthcare professionals. One of the things we gain with experience as clinicians is we get better at dealing with that complexity. We don't really recognize it, we don't write it down, we don't necessarily reflect on it, but it is real. How do we expose clinicians to that earlier in their training, normalize it, and give people confidence on their professional journey, and recognizing we're all on a professional journey and it's a very long journey. There is no destination in medicine. It's always a journey. I'll probably stop there. Oh, last thing, sorry, the commissioning point. Commissioning does not come across as a sexy topic, but the government white paper this year about how we're going to integrate commissioning and break down some of these artificial divides between primary, secondary care. Patients don't see primary, secondary care. They see healthcare, they see an NHS, and they are endlessly frustrated that we don't talk to each other, that I have no idea what Russell has written in his clinical notes when the patient or their parent come to see me in surgery. And he has no idea the conversations I'm having with them or the challenges we're all dealing with. That has to end. And the commissioning and the legal stuff behind it will hugely help that. So whilst it may not float your boat, it is important. And I would urge those of you, particularly anyone with an interest in medical politics, to listen keenly and speak up over the coming year as this goes through. Thanks.
Thank you both. Right, fittingly, the last word to Emma Sparrow before we close this session.
And just super quickly, so for some of the practical tips on how people can skill up around mental health, We Can Talk have created a free online training resource, which is young people based for anybody that's seeing more mental health admissions in EDs. And that's been done with HEE. There's also Future Learn have done a psychological first aid free course, which is specifically around COVID-19, which I'll pop the link into the chat as well. And MindEd, which is a whole suite of mental health resources that the college was involved in, along with other partners, is also available online for people to use and look at. And certainly as a team, based on what the young people have said to us through State of Child Health and Paediatrics 2040, we've just completed our mental health first aid training with the Mental Health First Aid Association, or Mental Health England, and that was a 2-day course, so not a free one, but really, really useful. And I think that links back to what children and young people have asked us, is to try and make every contact count in terms of mental health. So I think that there's a couple of resources out there and a few more on our website as well that have been co-designed with young people to support those discussions. So I'll pop some of those links into the chat too.
Fantastic. Thank you so much. Thank you so much for all your questions. Some of them are along themes that I think may come up later on in our discussions of the other work streams. So I just wanted to say a massive thank you to Russell, Helen, Emma, and of course a special thanks to Anwen, Bryn, Demi, Izzy, Nora and Toby for sharing their thoughts with us, I think very powerfully. And I'm delighted now to hand over to Dr. Simon Clark for the next session. Thank you all.
Hello, hopefully you can all hear me, and my NHS Steam driven laptop has unmuted and switched on the video at an appropriate moment. I'd just like to very much thank Hannah, Helen, Emma and Russell for that excellent first session. It's always a privilege to be part of these RCPCH events. And thank you all for joining us today. We are thrilled to be launching the Paediatrics 2040 project and what the future may hold for us all. A reminder for you to check out our microsite, and I think microsite's one of these new portmanteau words that describes a website within a website. Mind you, if your web browser has got any power behind it at all. Just typing Paediatrics 2040 in your address bar will almost certainly get you the paediatric microsite as the first result. But you can get to it also via the RCPCH website or directly using paediatrics2040.rcpch.ac.uk. So I'm Simon Clark, and I'm the neonatal consultant in Sheffield, and I've the honour to be the Vice President for Policy at RCPCH, and I co-chaired the New Models of Working session, and you'll be hearing from my co-chair Nicola Jay later on this morning. We also have massive support from Alison Firth and indeed all the other staff at RCPCH, and I know Russell has thanked them already, but without their fabulous support, this project would not be the blistering success that it's been. I mean, I'm quite a big consumer of science fiction in terms of books, films and gaming, and I'm all too aware of the issues to do with future gazing. We've really tried hard to make sure that we don't have any flying car moments in this project, and I'm sure you're all familiar with what the future holds for you, and then feeling slightly disappointed that we still haven't got flying cars despite their appearance in movies like Back to the Future, Blade Runner and a whole host of others. We've also tried to look past those things that are transient and made sure that we're going to look on stuff that's going to be here to stay in the long run. How many people listen to music on compact discs or iPods anymore, for example? A bit of transient technology that came and went. So I'm going to introduce my speakers in a moment, but just a couple of technical recaps whilst we're thinking about these things. Please put your questions in the Q&A box if you have any during the talks. That would be most helpful. If you lose your connection or struggle to get back on, don't worry, the event is being recorded so you can catch up at a later date. And if you keep the questions coming, that'd be great. So I'm going to introduce Steve Turner and Damian Roland shortly. They've been our leads on data and innovation. We've got about 10 minutes from each of them, followed by 15 minutes of questions and answers, during which we'll be joined by Dr. Venkat Reddy, who is our Officer for Digital and Technology, who's been newly appointed. So I'm going to hand over to Professor Steve Turner now. He's a paediatrician working in Aberdeen, and he's been the co-chair of the data work stream of the Project 2040. Some of you may also know that he's our Officer for Scotland, making sure that we truly represent all 4 nations of the United Kingdom, and indeed is our now Registrar-elect. So Steve, are you good to go?
Thank you very much, Simon. I'm just looking to share my screen and we can get going. So I'm going to presume that you can see my slides. So welcome to sunny Aberdeen, people. Such is the wonder of Zoom. You can zoom around the place in the blink of an eye. This is going to be a talk of 3 halves, and we'll build on what you've heard before, and we'll hopefully link into what you're going to hear in the next couple of hours. So at the risk of stating the obvious, change is the norm. This is a timeline that I've put together that tries to capture what I think are some key moments in paediatrics in the 25 years since the college was inaugurated. Apologies if I've missed out on your issues that you think are important. But what I have done is I've included and pointed out 3 areas there which link into other work streams of Paediatrics 24. So here we see an innovation, and Russell's already mentioned this. We also see a change in the model of care, which Nick's going to talk about later on. And then also we see something I think we all remember about a time that signified a step change in our approach to working lives. So at the risk of repeating what Russell said earlier on, the future is coming, folks. There's now what we can do about it. Russell's looking forward to a cocktail and umbrellas, and other of us have got a little bit longer to go, but I think we should embrace the future. But the future's an unrewarding business. Bookmakers make their life out of the unpredictability of future. And the guy on the right is doing what I think a lot of us are doing when we're trying to predict the future. But it was Lord Kelvin who boldly said, if you can't measure it, you can't improve it. And the data work stream of Paediatrics 24 set out to do a number of things There's an awful lot of data that have been gathered. For the intrepid reader, that will be captured in the report. But there were two themes. There was the global burden of disease. This is an international way of working out and describing the burden of illness, the impact on the quality of life of people, and it's stratified by age, and it's a uniform worldwide gold standard tool. We did that using paediatric data for the 4 nations of the UK. We also tried to capture footfall activity across the 4 nations, and this was in terms of the number of children coming to emergency department, the number of children seen in inpatients, as outpatients, and who were having consultations in primary care. And we modelled past activity in an attempt to predict future activity. So I'd like to think of some really tricky questions about the modelling, because I did none of this, but Russell will be delighted to answer your tricky questions. So this slide just basically summarises some of the data that we've got. So the global burden of disease was for the whole of the UK. We did attempt to get data from all 4 nations, but we're only able to get them from 3. We were able to get data from different time periods, all of them spanning a decade. And we were able to stratify by age and deprivation, and also in some areas, in some nations, by other outcomes. So suffice to say, we've got a huge amount of data. And you'd be delighted to hear, I'm only going to share 2 slices of the big data pie that we've cooked. I'm going to talk you through each of these slides, each of these slices, because there's a lot of data. So this is, first of all, looking at the global burden of disease. So on the vertical axis of this log transform scale, we've got the proportion of burden due to each of a number of domains. And we've got the domains on a horizontal axis. This is going to be a bar chart that stratifies by age. So perhaps it's easier for me to show you, and then you can understand what we're talking about. So if you look here, this is looking at neonatal and prematurity complications and how these impact on the burden of illness. And you can see that perhaps not unexpectedly, in infants, it's a considerable burden. But even in individuals who are aged 20 to 24, about 5% of the burden of their morbidity is attributable to what happened 2.5 decades earlier. If you look over here, perhaps not unexpectedly, anxiety and depression is not something that features in the preschool area, but does become more prevalent as people become older. Now, one of the nuances of the global burden of disease is that they consider individuals up to the age of 9 as one sex, but thereafter they dichotomise by gender. So this slide here looks at the burden of illness, burden of disease in females aged 10 and above, and I can just toggle down and show you what happens for the males. I think what's notable is that if we look at the far right hand, the burden of headache is lower in males, and the burden of anxiety and depression is also slightly lower in males, and conduct is higher. So you might well be saying, well, this is looking forward. What are you doing looking at backwards? Well, you've got to know what's happened in the past to be able to predict the future. And looking through these slides, I look at my training and think, well, I really probably need to have more training in managing anxiety and depression. And Emma's been talking about this before. I think this is going to become very much part and parcel of what a general paediatrician needs to be doing. We're looking at anxiety, depression, functional symptoms. So I think that looking back actually does give us a chance to reflect on what we could be doing for trainees now rather than in the future. So the second slice of the pie that I'm going to show you is the modelling. The modelling predicted the future, and there were 2 variables that were considered. The first is looking at poverty. We know that poverty impacts on health and well-being, and the poverty projections were no change, decreasing poverty, or increasing poverty. The second thing that was looked at in the modelling was how COVID was going to impact things. So we all know that I guess we're just coming through the worst bit of COVID, said he, touching wood. We know that clinical activity is down. If we do not change integrated care, the activity will basically return to baseline, and that will be the COVID shock. If, however, as part of the post-COVID reorganisation of healthcare that's been talked about by Helen, if we have moderate integrated care, and this includes 50% of what are called primary care sensitive conditions being managed in primary care, I emphasise not by GPs, paediatricians can work in primary care as well. And then the green line is the sort of the utopian if all primary care sensitive conditions are measured or are cared for. So I'll first of all show you the overall picture. And the main point of this is to show that, hey, all of the lines are going up. If we do nothing, the system will break at some stage. The time scale is from 2000 to 2020. Let me just drill down into data. So in infants, what we see here is that the rise in admissions is fairly consistent regardless of the poverty projection. If we do nothing for COVID, surprise, surprise, nothing changes. If we manage 50% of primary care, primary care sensitive conditions, so this would be the screaming infant, lower respiratory tract infection, otitis media, we get a much slower rise. And if all primary care sensitive conditions are managed in the community, then clearly we see a very different profile. So these profiles aren't the same for different ages. So if you look at the 1 to 4-year-olds, the gradient of the curve is not so great, but rather like the infants, there's no impact here of poverty, and primary care sensitive conditions do make an impact. But as we move to the 5 and 9-year-olds, and perhaps if I move forward to the older children, the poverty impact here is more clearly seen. Whereas the COVID shock and the integrated care impact is perhaps not as clearly seen as it is for the younger individuals. So those are the overall picture again. And this is for admissions to hospital. So there'll be different charts for outpatient attendance and for GP footfall. And these, I think, were limited to just English data. And this is my last slide. I think the important bit is on the right. Doing nothing is not an option. We have to do something because the system cannot cope. I think what the data demonstrate is that there is almost certainly an unmet need at present. And I think most of us would recognise that CAMS is a big problem. I think the burden of headache in the community struck me as an eye-opener. Pain is also an important thing that I always think is something that is somebody else's problem, but probably needs to be my problem and needs training. Looking forward, there are some huge unmet needs in the future. And if we do nothing, I think things are going to get very difficult. So there is a need for innovation in terms of pathways of care. There's also a huge amount of work that we've done that I haven't shown you about which conditions are going to get more prevalent over time. So for example, functional symptoms, complex conditions, and which conditions are going to get less common over time. And these are mostly going to be communicable diseases. And so what are the solutions? Well, the solutions lie in the hand of the 3 work streams that you're going to hear about later on: innovation, models of care, and staffing. And that is me. Thank you very much.
Thank you very much indeed, Stephen. That's just brilliant. Huge amounts of data collected and analysed there. And I think that it's a testament to all the hard work of everyone in the college that that information has led to some predictions of the long term. If folks have got questions about that, please put them in the chat box and we'll come back to those after we've had our second presentation, which is from Damian Roland. And Damian is a paediatrician in Leicester, and he's been the co-chair of our innovation workstream. He's a consultant and an honorary associate professor in paediatric emergency medicine, and he's going to tell us what the future is going to be like from an innovation and technological perspective. Are you ready to go, Damian?
Hi there, Simon. Can you hear me?
Yep.
Excellent, fantastic, and hopefully the slide is up. So thank you very much. So with actually a relatively large group of people, we've been looking at innovation and technology The rest of the working group are really bored with me because at virtually every meeting that we had, I raised my little digital hand on our Zoom call to discuss what we actually meant by innovation. And it's something that I've been ploughing on with for most of the last couple of years of this project. Is what we really think of as innovation is a very variable beast. An example I will give is that Zoom, Teams, these are all technologies which have been around for years. Zoom actually reached its peak on the stock market in 2017, valued at over £1 billion, but it's only really now that it's been pushed into practice by COVID. And there are lots of other examples of things which sound really funky and neat and are amazing technologies, but actually they're perhaps not that innovative. They just needed to get into practice. And so we've tried to take quite a broad view of what is innovation and technology. And I've borrowed this particular slide from a chap called Dr. Simon Dodds, who works in kind of innovation and implementation. And I like his breakdown of there are things that which we invent, there are things which we innovate, investigate, and implement. But the important thing is that they improve. And I think what we've looked at is a number of different topics in this project, which hopefully will provide some improvement through innovation and technology. How have we done this? Well, we've taken gone back to basics, I suppose. Let's do a large literature review, looking at the impact of health technology specifically on the delivery of paediatric care. And as you can see, it was a pretty large undertaking, over 5,500 different bits of literature reviewed and screened. And these were brought down into a paper which has just been published in preprint, which is a narrative synthesis of over 120 different types of paper. What did we find? Well, we found a number of things that we need to think about and that the rest of the working group looked at in terms of some of the topics that we've identified. So if you go to the website and you look at your report, you'll be able to see things about apps, artificial intelligence, genomics, sensors, big data, virtual reality, wearables, loads of different examples of things that may make a meaningful difference to patients. The challenge is I had this dream at the beginning with Hannah, who was my co-chair for the project, about how we provide some brilliant examples that may change the world. But if you look at wearables, for example, there are over 500 million different types of wearables going on or available at the moment. And so it's not possible to individually rank and list one. We can only just give some broad stroke themes. But what we have been able to do through the literature review is set some clear precedents. So we have learned that we need clear guidelines. We need, how do we implement technology into practice? And we need to understand that healthcare professionals themselves can be digitally naive, that they can struggle just to log on to computers sometimes. That young people tell us they like continuity of care. So if you have a technology that disrupts continuity of care, that doesn't bring your records through, that's a non-starter. Confidentiality comes up again and again and again as an important attribute. And this just isn't locking everyone out so they can't see it. It's making sure that everyone who is party to a digital technology understands what it means for them and who it's going to be shared to them. But when we talk about digital technologies, we need to understand there's digital poverty. COVID has really highlighted the extent of childhood poverty in the UK, but digital poverty is an aspect of that which we need to address. Not everyone has access to the same tools, and that's what Russell mentioned at the beginning. Co-production seems obvious, but it just doesn't happen. Loads of people very happy to work with adults for their device, unwilling to work with children and young people for exactly the same device. And a core finding, and again, this is probably self-evident, but technology and digital innovations need to supplement, not replace what's going on. There's no point in replacing things that work with things that make things more difficult. And then as a kind of a closing point, one of the issues has been is that do we have the right infrastructure to deliver technology and innovation in the future? And Professor Paul Dimitri has been working through TICH and has produced a number of reports about how we need to change the regulatory framework to ensure that digital technologies and new innovations for children can get into practice. And what he highlights again, and I think this keeps coming up, is if you do not invest in children and young people in their deployment of technology, it will just not work. So I'd like to finish with a couple of pictures from Isla and Ewan, George and Lewis, and the key themes of what we've done is that innovation is not simply the development of new ideas, that children and young people are often an afterthought in their development and delivery, and we need to solve that, and we need to solve that fast. And finally, we need to look at the landscape of research and development to ensure that it's child-centered rather than just being something that is an add-on to adult practice. I would really like to thank Alison Firth, who has done an amazing job in bringing the innovation workstream together, Safia, who led the literature review, reviewing over 5,000 papers, and my co-chair, Hannah Jacob. And I've listed all the people who have helped us with the case studies and the examples that have been so helpful in writing this report. Thank you very much.
Thank you, Damian. That was extremely useful and a helpful view into the potential of innovation. If people have got questions, if they could pop them in the chat box. We've got about 12 or 13 minutes to discuss these things. As I said, we're very fortunate to be joined by Dr. Venkat Reddy, as well, who's been appointed as our digital officer. He's already rushed around meeting various different individuals within the college to help us with our digital journey and ensure that we integrate various pathways. And I would be really grateful if he could give us just some thoughts on the talks that he's heard and this section about the burden of future disease and innovation from a digital perspective. Dr. Reddy.
Thank you very much, Simon. Thank you. First of all, I'm so excited to be the first ever Officer for Digital Health and Technology. I think our college is the first in doing so, and it is the best time to be in this post, really. I was so glad to see and hear the young people talking about what their priorities are, because that's where we start. And also so glad to hear them talk about integration of physical health and the mental health and the technology helping us to do the right thing rather than getting in the way. Those are really, really important. And digital transformation, people get really, like when Damian was talking about innovation, you can cut it in different way. And same thing with the digital transformation, it means different things to different people. I am very lucky to be part of the NHS Digital Academy, where we are being mentored and taught by the best brains within the NHS England and outside world as well. And the one thing we agreed on, the simplest way to understand is when we look at how we conduct our lives in terms of ordering from Amazon or getting a takeaway, getting an Uber, booking our holidays, or getting, we need to get to similar friction-free, easy to achieve healthcare processes in the systems. That's the way I look at it. As far as my reflection so far, when I read through the innovation piece and the whole 2040 last night, we covered almost everything we need to cover. It's a matter of implementing it and also keeping in our mind that people, processes, and the culture come before technology. And we can have the best technology in the world, but if we don't use it, we don't develop it with our children and young people and fit it into our existing workflows and change the way we work, it won't result in better outcomes.
Thank you. That's a very insightful review of that. I'm just looking through the chat box now, which I'm just struggling with the number of screens I've got open to make sure that I'm looking at the right bit of chat. And one of the questions we've got is, should our curriculum have some aspect of digital training in the future to ensure HCP utilize digital platform better? Venkat, I think that's probably one for you, isn't it?
I mean, I think that is the key, because we can, that often happens. We buy shiny big pieces of kit from abroad for millions of pounds, but we don't train and support our staff to use it and adapt it, because there is no system which can be dropped in. And we hope that we sprinkle some magic fairy dust and it will solve all our digital problems. It doesn't happen. We all need to look at the basic minimum level of digital literacy for all of us as professionals, as well as for our young people and the families, especially who are at the risk of digital exclusion, not just from the healthcare. If you want to access any benefits and the social support, you need to have the minimum level of digital literacy. So there is already fantastic programs, building digital ready workforce from Health Education England, and I will publicize it widely, and we need to do that. I think another thing we're doing is to avoid duplication. For the first time, digital health officers from all the Royal Colleges are coming together under the auspices of Academy of Medical Royal Colleges to look at and to develop a consistent curriculum without duplicating it. People are more interested in clinical informatics. There is a UK Faculty of Clinical Informatics. I would ask people to look at it. And there's a lot of training programs through the NHS Digital Academy. There is Topol Fellowships. There's a lot of it is out there. And one of my key aims is to get it all out to everybody so that we can support everybody at different levels of needs and aspirations.
Thank you. There's a couple of questions here that I think are overlapping slightly, so I'm going to ask them both together and go to Steve to see if he's got an opinion on this, and potentially then Damian. It says by 2040 we should be in a situation where the vast majority of children and young people in England have a personal digital record which goes right back to their birth and potentially draws information on their mother's pregnancy. What do you think the implication for this will be for innovative ways of working and improving outcomes? And that's linked to very much, is there a way to include maternal mental health in the early years that contributes to our long-term problems for children, especially in the first 1,000 days? As you'll be aware, there's a real opportunity at present in Scotland, definitely for Steve, to influence the input into perinatal infant mental health services. So Steve, what do you think the burden of disease? Are we going to be able to intervene even earlier if we've got decent child health records?
I think there's a couple of things going on there. I think that integrated health records, such that wherever you are in the country, you should be able to, with privileges, access the records of anybody else, will be a huge step forward. I think the comment was also about, and I might have got this wrong, whether individuals would have their own records. So I, as a patient, would have my NHS.com place where I'd be able to go and have a look at my records and my results. I think the issue as to how this is going to reduce the burden, I think, is somewhat distant to just having records. I think if you're going to reduce the burden, there's not a lot that just data alone can do. You can certainly measure the burden, but whether it can change the burden remains to be seen. So I think I'll dodge that one. But I think integrated healthcare records and individual record will absolutely be the norm in 2040.
Damian, do you think that that's going to make a dramatic difference in the emergency department and other centres seeing young people if we've got the digital handheld, the red book that's then digitised with data going all the way back to preconception almost?
I'd agree with Steve. So I don't think it's completely transformational. I do think that the ability to have everything together so we can collect and analyse data will be hugely impactful. Just a really quick example. So we have something called the emergency care data set. It may be something that paediatricians don't know a lot about, but if you work in an emergency department, you are meant to, but not everyone does, code according to a common format so that we can all emergency departments can be compared equally. We can't do that at the moment. And there's so much in medicine that we can't compare equally. But something that came up during the development is whether we should be able to code for umbilical granuloma. And some clinicians in a particular region of the country got quite vexed that you couldn't initially. And the reason they got vexed is they see loads of it in their emergency department. And this is just a really good example of how when you start bringing data together, you do realize the inequities and differences we have between regions and nationally. And that to me is the importance of being able to get child health records together, because then we can start really looking at being able to provide data that demonstrates that what we all know, that there is inequity driven by poverty and social disparity, and that only by showing and shining a light on that and showing how much it affects children will we be able to produce the change that we need.
Yes, I mean, I think that's probably a truism. Venkat, do you have any insight into that?
It's interesting, really, because if I come from the more technology side of things and also being involved with Original Connecting for Health, and I'm very privileged to work in an integrated physical health and mental health community service where I was a clinical director for people all the way from health visiting to tier 4 inpatient mental health. For us, it absolutely makes a difference because we started out with the TPP system, one of the earliest to go into full electronic health record, and having access to the GPs also being part of that, and intermediate care, walk-in center. And as far as the safeguarding is concerned, complex neurodisability, mental health, physical health, able to see it all makes a big difference for us. That's the point I would make. Clearly, moving it one step forward and able to join that with the EPIC electronic health record from our local teaching hospital as a part of our local health and care record would absolutely make a big difference with social care as well. As far as the looking from young people and the family's point of view, those systems already exist. For example, TPP System 1 has a parent-facing, patient-facing app which you can download and interact and look at your notes and share information. And it's actually critically important now. For example, we digitized our autism pathway, and the way we look at social communication is parents uploading a set videoing set play sessions and able to upload it, and pediatricians, psychologists, and speech therapists able to log on and code them for autism. So it's already there, Simon, and we need to make it work across, as we said it again and again. It's not evenly distributed.
Thank you. I think I'm going to make this the last question. Thanks for all the questions that people have put in. We'll try and answer the rest of them during the course of the webinar offline. People are very keen to have Venkat's email address if he's willing to share it with folks, as he's clearly an expert in IT integration and things like that. But as our Officer for Digital, he's contactable via RCPCH should you want to chat with him. But I think the last question, which I think Venkat may have touched on, is this one from, due to the varying IT systems within the NHS, we all know there is difficulties in accessing previous bloods, x-rays, discharge letters, GP prescriptions. How do you, which I think means the RCPCH or Project 2040, plan to work with the outsourced IT systems to help interlink these despite the different healthcare platforms that there are? Venkat, I think that's probably one for you specifically.
Yeah, I think this is being looked at clearly by NHSX and how we commission and implement and adapt IT systems and the subsystems. And whole of one of my modules on PGD for digital health is all about understanding how they developed, how they fit together. And I think we either go trying to buy tiny little modules, one for electronic prescribing, one for digital radiology, one for pathology, and fit it all together. That takes up a lot of time and integration, interoperability challenges. Or you buy a one-size-fits-all big system like an Epic or Cerner, which is a little bit, it works well for that organization, but difficult to interoperate with the rest of the system. But the current framework is to look at, set some guidelines like NHSX does that. Any product that meets that framework requirements will be put it out there for the organizations to select and work together. The open standards and interoperability not getting locked in terms of a single provider, single system, single data types. That's becoming more and more common. And I'm very happy to help with any people who might be struggling with that and how to go about. And I would say that if you already are not, make friends with your chief information officers, chief clinical information officers, and chief digital officers, if you got them. And I got a list of all of them. I'm networked with about 300 chief clinical information officers. I can put you in touch with them and help in those regards as well.
Thank you very much for that, Venkat. That's very useful. And any tips you've got on using fancy buzzwords to communicate with those folks would be probably very helpful if you could put those in the chat box to make sure that we're all speaking the same language. And now I'd just like to thank our speakers, Professor Steve Turner and Professor Damian Roland, for those really helpful presentations and the answers to the questions that they gave us. And now I'm going to hand over to David Evans, who's going to chair our next session. Thank you all very much indeed.
Thank you very much, Simon, and good morning from Bristol. So we're moving on to the next session, and just to remind everybody, there's lots and lots of information on the Paediatrics 2040 microsite. As Simon said, if you just pop it into Google, you'll find it, but if not, it's paediatrics2040.rcpch.ac.uk. So I'm David Evans, I'm Vice President for Training and Assessment, and we're moving into the session where we consider the future models of care and also thinking about working lives. During the session, of course, you can put your questions in using the questions and answers, and we'll try and monitor that along the way. Each speaker, which I'll introduce in a second, will speak for 10 minutes. And then we'll have some chance to answer those questions. We can answer the questions afterwards as well. And also, don't worry if your screen freezes or there's technical problems. We are recording the session and they'll be available on demand later. So it gives me great pleasure to chair this session because, of course, it's very tempting, isn't it, to predict what might happen in 20 years' time, because by the time everybody gets to 20 years, the people who've been responsible for predicting it will probably, myself included, hopefully, be on a desert island somewhere with our gin and tonics and cocktails and be well out of it. So we can't be held to account. But I think Paediatrics 2040 is different because it's the start of looking towards the 20 years. And also, when we come to these work streams, we've thought about the data and we've thought about the innovation, but now we've got to think about, well, what does that actually mean? How do we care for our patients? And also, how do we care for ourselves? And I think working lives is really important too. And it's very pleasing to see that children and young people recognise that looking after one's own health as a doctor is really important. And it's important to the children as well. So I think that was they have a very mature reflection of what it takes to be a doctor. So without further ado, let's get started on our third session. And I'm very pleased to introduce some of the speakers. First one, it will be Nicola Jay, who has been one of the leads for the Models of Care workstream. And then there'll be Judith van Voort, who's been one of the leads for the Working Lives workstream. That's the one. And also, we're going to be joined by Dal Hothi, who's our new officer for retention, and she will join in the questions and answers to think about how we can use some of the ideas we've talked about and some of the putative plans and put them into use for the future. So first of all, I'll introduce Dr. Nicola Jay. You may know Nick because she's fairly well known, particularly in her role as the RCPCH Officer for Workforce. And she has been co-chair of the Models of Care workstream for the 2040 project. So Nicola, without ado, are you ready?
I think so. Thank you for that introduction. It's such a pleasure to be here today. I'm going to share my screen, hopefully, and have my presentation here. So the models of care workstream really comprises kind of all the work that you've contributed to. So this very much is a summary of what people are doing and what people's hopes are for the future in the way that we deliver services. So there's 4 real components to this, and that was the initial group that was got together through the request to help support this project that Russell sent out kind of 3 years ago. And then we have all the work that the children and young people are doing via Emma's work through the college as well. We have the survey that Alison did, and we found out what you wanted in terms of future models of care. And in the last few months, I've been reaching out to different people across the United Kingdom in terms of what they're doing and what they're doing differently, and what evidence they have that what they're doing differently is helpful to children and young people, because that's something that we, we always need to do. We're very good at thinking about how we may change things, but perhaps sometimes we're not quite so good at making sure that what we change is effective and improves health outcomes for children. So why do we need to change? Well, the way that we deliver services at the moment has been the same since the inception of the NHS. So we have hospitals, we have primary care centres, and we have this disconnect at times with a huge gap between services that's unhelpful to children, young people and their families. We aren't meeting the needs of children in this country, and we know that poverty is a huge issue. One of the things that's often said about the NHS is, well, it's free, it's free at the point of contact, but increasingly families find it really difficult to get to that point of contact. If you're a single parent, if you're on low income, if you have other children at home, then going to ED is problematic. If you don't have a car, then how do you get there? Do you call an ambulance? Who helps you? If you don't have very much money, then it's expensive to pay for taxis. If you go into an outpatient visit, then that costs as well to get to that visit. Families don't have that kind of money, so we have to think about people and access to services. We also need to think about the environmental impact of the way that we deliver services, and you'll hear common themes throughout all these talks, and that's one thing that's been really important during this project, is that everything that people are saying is the same, really. We're all saying the same thing in terms of what we want to see for the future. So this is the summary slide from the question to you as healthcare professionals in terms of what do you want to see differently in 20 years' time? And the overwhelming response was moving care out of hospitals. So into the community, close to families' homes, strengthening that primary care, communication strategy, that primary care paediatrics, working with our primary care colleagues to make sure that we're all singing from the same hymn sheet and doing similar things to improve health outcomes. It talks about virtual consultations, and we've seen a massive increase in these during COVID. But what we need to do and make sure of is that what we're doing is effective. So understanding and analysing the information that young people tell us and how we make sure that we meet their needs. We had feedback about staffing, and so we know we've got a huge problem with workforce, and we know that actually this is being addressed. As always, we said we've got an office for recruitment, an office for retention, and there's some projects going forward that are going to have a huge influence on paediatric staffing in the future. We also need to think about multidisciplinary teams. It's not just about doctors, it's about everybody who wants to look after children. And that's something that we'll talk about a bit more later on. Public health, you spoke about how we need to be more preventative and be less reactive. And a little bit we'll talk about what does a good consultation look like? What should we think about when we see children? What about those touch points when we come into contact with children and families? And also using technology and strengthening IT systems that Damian's discussed already. So I won't kind of talk about that further. So here again, we can see that child or young person at the centre of care. And what we really do believe is that this needs to be the underpinning philosophy of all that we deliver. We thought about how we kind of structured this section. And initially it was a thought about the services, but actually the services are less important than the child. So we need to think about the individual children and what they need. We need to think about why we deliver services, where those services should offer, who should deliver those services, and when should they be, and how do you do it? So we talked about the digital, the face-to-face. Is it in hours? Is it out of hours? Is it in the place of residence? So is it actually in a care home where a child is, rather than making them come to the hospital with their carer? Why are we doing it? What is the hope from that encounter? What are we trying to achieve in that encounter? And to do this better, we need to think about different ways of integrating. So we need to think about horizontal integrating. We need to think about working with our social care colleagues, thinking about housing. If a family and child become homeless, that really is going to have a significant impact on their health outcomes. So how can we intervene? How does it, what does it matter? How do we work with those housing officers to make sure that we understand what's happening to the children we care for? Thinking about education, young people constantly ask for more support within their school environment. They don't want to leave their lessons because that's where they do their learning. Education is the one thing that takes children out of poverty, so we should be supporting them in that endeavour. The vertical integration between primary and secondary care, and longitudinal, thinking about the kind of the life course of children, moving through adolescence into adulthood. How do we make sure that we have that continuum in place so there's no gaps in services, and thinking about the whole child? So this is the whole child approach, the population health approach, which Bob Claber and Amanda Watson put together a number of years ago. And we split up the models of care into these different areas. So the healthy child, the vulnerable child with social needs, the child who's got a chronic illness, but just one condition, such as diabetes or asthma, the child who's got chronic illness, but they're medically complex. So we know that there are increasing number of children with medical complexity in the United Kingdom, and we don't meet their needs for a number of reasons. We talked about the mild, moderately, acutely unwell child, and also the severely acutely unwell child. In the next few slides, I'm going to concentrate less on these two areas, but there's lots in the models of care that discusses this and also talks about different ways that people around the United Kingdom have used services change to make improved health outcomes. So keeping children well and how best to use contact points. So when a child comes to see us or comes to see a healthcare professional, they spend lots of time waiting. They spend time waiting to be weighed, they spend time in the waiting room waiting to be seen by us, they wait for dietitians or they wait for physiologists. So how do we use that time well? So if they're going to come and see us, let's make sure that those contact points are effective. So perhaps thinking about having dental hygiene stalls in our outpatient departments, thinking about videos that they can access, perhaps thinking about how we assess parental literacy, thinking about then, can they read to their children? Thinking about their mental health, so asking questions about, how are you today? What's happened since we last saw you? Is there anything that I can help you with? Not just the routine questions that we ask about the condition that they come to see us for, but thinking about them in a holistic way. This means we can identify problems early and then we can help support them and intervene if needed. The vulnerable child. So the child with a social communication disorder, we know this is a huge problem at the moment. We've got massive waiting lists. We've heard about some really good integrated care services and how digital technology has been used effectively to reduce the waiting times and make sure that the children get the diagnosis earlier and make sure then they get the help and support they need. Every month or year that they waiting for these kind of diagnoses to be made is years when they don't access their education, they become less socially aware, and actually we know there are poor mental health outcomes for children who have social communication disorders, and we need to work in this area better. We also know that children are not responsible for the environment that they're born into. We know that children who've got a medical diagnosis have unmet needs. We know about adverse childhood events and deliberate harm to children. These are all areas that within the models of care document, we talk about how perhaps we can meet these needs. So thinking about adverse childhood events, do we need to start asking these questions routinely as part of routine inquiry? This is something that people are discussing. It's something that's being done in other parts of the country and other parts of the world. How do we marry up the kind of the systems that adults take part in? So if a woman goes to ED because of domestic abuse, how do we make sure that the people looking after those children that she may have are aware of what's happening to her? How do we do this in terms of our digital technology, our communication strategies? These are all things that we need to be thinking about. The child with complex needs. So this is an area that we really need to concentrate on. This is a care map from some work that's been done in the US. It's been reproduced by the permission of the mother of this child. And this was just her attempt to put down on paper all the people involved in her child's help and support network. When we're in a clinic, we don't see this. We don't see all the complexities, all the people they have to liaise with and engage with. And perhaps if we did, we'd be able to help better and offer better support. We know that there are kind of moral imperatives in terms of getting this right. There's been lots of very difficult cases over the last few years, both from a professional point of view and the child point of view. We need to make sure that the events that occur in children where there are medical complexity, that there are effective strategies that we put in place, and there is no people who are disadvantaged or they're left needing or wanting things that otherwise we could offer. And then towards our final slides, we think there are some essential components of any service that should be offered. So we're thinking about how we work within teams. So we know sometimes that we have difficult teams. It's about addressing those differences that we may have, because we know that if we don't, this will have an impact on the health outcomes that we deliver for patients. We know that from the work that Professor Michael West has done, that if we work in organisations where we have dysfunctional teams, then actually the health outcome for those patients is poorer. So this is something we need to think about in terms of our paediatric teams. We need to make sure that we have a multidisciplinary team approach, both from the professionals and their background, but also who they are, the diversity that they can offer us, the richness that they can offer us in terms of thoughts and ideas about how to solve problems. Emma and all her young people have done some fantastic work on summarising strategies for child and family engagement. There's a few pages within our document about this. This is so important to what we do, to make sure that we co-design services. There's no point in us saying what children need if it's not what they need themselves. We need to have a patient-centred approach, and we need to make sure that quality improvement activity is embedded within everything that we do, so that if we change a service, then we look to see what we're actually wanting to change, and do we achieve that change? And if we don't, then we need to think about why we haven't achieved it and what do we need to do differently. So why we do what we do. So this is a quote from one of the engagement events that Emma had with some young people in Wales. And that what they say after looking at what we've done is, I feel reassured that moving forward, young people in 2040 will have their rights and wishes respected when treated medically. And I guess that's all we can ask for, is that that is what we want for the young people that we look after and care for.
Thank you very much. So thanks, Nick. So we'll move on then to the Future Working Lives workstream. I'm very pleased to introduce Dr. Judith van der Voort. She has been leading this workstream, and you may well know Judith either in her roles as providing lots of educational resources, effective education supervision, and other courses for the colleges, or as her role as head of school for Wales at the Welsh School of Paediatrics. A very great enthusiast for education. So without further ado, Judith, are you ready? And let's hear about your work stream.
I hope so, David.
We can hear you.
You can hear me. Can you see the slides as well?
Yes.
Yes. Right. Thank you, David and Nicola, for such an inspiring start of this session, but a completely inspiring morning. It's my pleasure to give you a little bit of insight into the working lives stream of this Paediatrics 2040. And when we started this, David and I met with a group of people interested in helping us, actually face to face, sharing ideas, chatting to each other, having a coffee together at the conference in 2018. Obviously, that then changed towards a slightly more solitary exercise, but in the end, a lot of you joined us again in what was, in the end, a very much a team effort. We started off with a literature review, looking at working lives and workforce elements of looking into the future. And there's quite a lot of literature. I certainly didn't do anything like what Damian did, but we had an idea of what was needed with regards to working lives when it comes to workforce. And this is an absolute essential aspect of looking into the future. Without the right workforce management, we will have staff shortages, and this can be anticipated and changes can be made. And as has already been said, often these changes are made in a sort of a short-term election cycle time frame. And what we really need is longer-term vision and longer-term solutions with regards to workforce. We then looked at some of the information that was already available from the college websites and workforce census, as well as the shape of training. Not surprisingly, the RCPCH had already identified a need for more paediatricians, with an increase in recruitment and an improvement in retention, but also an expansion of the non-medical workforce. And this was very much what we have found in our work stream as well. The shape of training, actually looking at the sort of future of paediatrics in the next few years, had very similar ideas about flexibility and working alongside other specialties very much ringing through to the Working Lives in 20 years' time vision. We then saw the Paediatrician of the Future published, and I mean, I cannot recommend this document highly enough, giving a real impression and idea of what training can look like, if we implement that. And then there was the members' voice, which was very beautifully expressed through the members' survey just before COVID. And the question was, what top thing would you want to see different in 20 years' time in your working lives? And that helped us do a sort of a qualitative assessment of what you had to say. And that helped us then form 4 themes that we used within the working life streams to use the literature searched, RCPCH work, your voice, as well as our own ideas, visions, and inspiration to come up with this report. And we regrouped with the medical students, paediatricians, and retired paediatricians to form some ideas of what we'd like to see. The first very important theme, which has been expressed through all the morning, is flexibility. And we'd like to see rotas that are flexible to trainees, to educational opportunities, no fixed leave. And we'd like to see rotas that are maybe adaptable to seasonal differences if that is appropriate. We'd like to see post-to-post flexibility for trainees, and we'd like them to be involved with their choices. Maybe they want to stay longer if they're really fitting into a certain area, or if they have a change of career, then they might well want to change sooner. We'd like to see that in the future. There were ideas how training school flexibility should be incorporated, with training schools and deaneries offering open days to trainees so that they can find out if they're actually suitable to that particular school. We wanted to see wider career flexibility for medical schools and foundation trainees, but also for consultants and SES doctors, with credentialing, allowing the possibility of maybe changing your specific specialty much later after your training, or having out of program experiences like sabbaticals, and not just for trainees, but for all of us. And we'd want to see flexibility who does the job, and stop thinking that certain people do certain things, and incorporate nurse practitioners and physician associates to make the posts and the way we work and train so much more flexible. The second work stream was looking after each other. And COVID-19, I think, has spearheaded this to the attention of all of us. And this has become a lot more important. Your voices from the membership survey all mentioned it as well. Our well-being, our mental health, that of our families, but also of our patients and their families, is absolutely central to a future paediatric workforce. We've heard this, and we've heard our children and young adults mention how they want us to be trained in dealing not just with the physical side. And I personally believe that the separation between mental and physical is becoming quite old-fashioned, and these are things that are integrated and need to be addressed together. When looking after our own mental health and well-being, we realized from our work that not one size fits all, and that there will be many individual interventions that are already taking place. For example, a real understanding of burnout, places where we can rest, where we can have drink and food, mental well-being initiatives within health boards and trusts, including some mindfulness sessions. There will be institutional interventions needed. There was a cry for managing adverse events and complaints better, supporting doctors and the workforce when they're having to go through such problematic situations. Institutional interventions in working in teams and communicating better, and having leaders that are truly truly aware of the need to look after each other. And clearly, equality, diversity, and inclusion is an absolute central theme through all of this, and we will never reach a true well-being workforce if we do not pay attention to this. We found that this was such an important aspect of our working lives that the lead for this particular stream, Seb Gray and his team, produced not just a mnemonic on the right side summarizing some of the initiatives and ideas that we found, but he actually produced a fantastic supplementary report for all of us to find inspiration from, and I can't recommend it high enough, and have already used some of the ideas that are found in this report. Our third work stream was knowledge, skills and experience, and this overlaps with some of the work and some of the presentations you've heard this morning. And clearly technology has made us work remotely, has made us learn to deal with new ways of talking to each other. And this is going to progress. We're going to have paperless departments. We're going to be able to share our patients' information with primary, secondary and tertiary care. And we will need to have the knowledge to manage all of these systems. And I think Venkat mentioned, that we need to potentially have training in these areas. So technology training, artificial intelligence, robotics, we need to learn about these new things that are coming our way. Our medical knowledge will also need adaptation and change. We will need to move alongside the technology, but we will need knowledge about genomics, ethics, to allow us to communicate some, for example, health risks that our patients will have. Our genomics will be known to us, and this will come with significant risks to our well-being and health. And we need to be able to discuss this with our patients and understand their risks. We need to know about the enormous amount of data that will become available from monitoring devices that patients will carry along with them, like glucose or blood pressure, and how to help them change their medications and their lifestyles. Our clinical skills have already changed enormously, and they will need to move alongside all of these changes that I have mentioned before. And we also need to incorporate some non-clinical skills in finance, working with business, and understanding the importance of data governance, working with risks in sharing information with our patients. We need to understand data protection and safety. And these are all new skills, or slightly new skills, that we will need to incorporate in our combination of skills. And again, all of this will need to be incorporated in our leadership skills. Our last stream of themes within the working lives going forward was working together. And COVID-19 again has made us work together in a remote way, which is been a revelation, as well as something that we will need to work on and continue to be good at, because this is not only a good thing, and the children and young people themselves have mentioned that they would not want to lose the face-to-face way of working. Our collaborative working is so much more a possibility now, and we can think of working together with primary and care and mental health services, but also with our obstetrics colleagues and with paediatricians abroad. We want to be true paediatricians of the world. We want to understand climate change. We want to help health issues in other parts of the world, and we want to be able to work collaboratively with paediatricians all over, and not in our own little silos anymore. We've mentioned here who we want to work with, and we've said how we're going to achieve working with primary care and mental health. I haven't got time to go into that now, but we also want to work with social care, youth work, psychology, and art, music and dance therapists. And can you imagine looking after a child who's taken an overdose using poetry in your management strategy? And again, I can't emphasize enough that as paediatricians, we are have to incorporate all of what we've said today in our leadership skills to ensure that we are truly paediatricians of the future. We've then summarized all of these ideas and visions to something that we'd like to see in 2040. And this is a very busy slide that I would not want you to go and read now, because it's all in our report on the micro side. And we've then distilled some of the enablers and solutions or ideas on how to achieve what we've said. And probably it's not rocket science, what I've said here this morning. And it can start tomorrow. These are the ideas for a journey, not for something that we will reach or that we will achieve in 20 years' time. We can start this with the inspiration and the push for change that COVID-19 has started tomorrow and today. And very slowly and gradually, we will achieve a working life that truly reflects some of what we want to see and have expressed in this report. I can't thank Alison enough. It's been amazing working with her and David to come this far. And then obviously all the people who've contributed to the working live stream. And I've put Seb in capitals because his contribution has been exceptional. And then I will refer back to David now. Thank you.
Thank you very much, Judith. So I think this is going to generate some questions. I can see some already popping up, and we will open to questions in a second. But just before we do, as I promised, I'll just introduce Dr. Dal Hothi, who's a paediatrician in London, Great Ormond Street, but also is fairly newly appointed as Officer for Retention. And if Dal is online, yes, hi there you are, Dal. I was just going to ask, actually, just to kick off and think about reflecting on what would you see as your priorities coming in to try and help our working lives and to improve retention now, and how those fit with the working lives theme. Also, bearing in mind two of the questions and answers really follow the theme of one of the main barriers is the flexibility or the inflexibility, and that's caused by attrition or lack of training numbers or lack of trainees to fill the numbers.
Thanks, David. Great session and wonderful talks. Thank you both. Huge question for me, David, in my first year as in my officer role. I think the reality, I really sort of relate to what Judith said about flexibility. We absolutely need to translate that into some key aspirations. We need to arrange methods to ensure that there is flexibility in the way we as paediatricians are working, and that's essential as a trainee, but consultants as well. I think we also need to think about providing more training to allow us to become more flexible in the way we frame and sort of approach challenges in our working lives, so that we build the resilience, the mental, emotional and sort of cognitive resilience to deal with the uncertainty and the complexity of the future healthcare systems. And then finally, I think as a college, we need to be quite flexible in the support we offer our members. As I said, what matters to people can be quite different. And one of the things that really struck me when I sort of joined the college is the college really cares about their members, but we really perhaps need to expand the profile of support that we offer our members. And make sure that we ensure that our paediatricians not just providing service, they're not just mastering their profession, but also that they're having really good working experiences, and so they have a fulfilling lifelong career. So we really need to sort of perhaps change what we're doing as a college to make sure that happens.
Great, thanks. And so I see Nicola's joined us again, which is good. So I'm going to actually put one of the first questions to you, Nick, and that's, we had one question asking about the NHS white paper, and I guess if I was just to summarise the question or sort of rephrase it, what is it that the government are thinking, or are there in the long-term plan, and what is it in the long-term plan and the white paper that we can use to try and form these new models of care? So what can we use to our advantage, and where do you think the barriers would be as we try and form different models of care?
So I think there's a huge amount of work going on at the moment via the NHS England and the Paediatric Transformation Programme. And every week we get emails coming out asking us what we're doing about certain aspects of care within integrated care systems. So I think integrated care systems, I think, are something as paediatricians we need to engage with. We need to make sure that we have people there ready to answer questions. We need to we're getting groups together to look at the key areas that NHS England are focusing on at the moment. And those areas are things such as integration, the things such as preventative health, obesity, thinking about the single long-term conditions such as asthma and diabetes, epilepsy, all the things that we have highlighted as needs for our children are things that NHS England are taking on board and working with. So that's to our advantage. It's probably the only time for a very, very long time that NHS England have got lots of people working in their team to help support us, and we need to use that to our advantage. The barriers will be the kind of the knowledge around that policy and politics and making sure that we have good leaders in paediatrics. So making sure you're up there, and if you don't understand what's going on, ask the questions. I don't understand the whole time, and I go, help. You know, what is it? I don't understand this. What's that meaning? You know, just tell me what you're trying to get to, you know, and don't be afraid to do that. And also don't be afraid to shout for children. So, you know, people sometimes will kind of not dismiss what you're saying, but actually there's a huge number of other kind of areas they're focusing on. But we have to be that voice. And so you have to repeat yourself time and time again. You repeat yourself. I'm here. This is what I'm here for. This is what we're going to do. And it's that repetition that eventually actually, you know, gets stuff working and going.
Yes, thanks, Nick. And so just moving then to Judith and think a sort of similar question about what would be the priorities. And I wondered whether when you first started this, whether your priorities have been changed by COVID, or whether you think that COVID has just sort of reinforced what you believed were the priorities.
I definitely think that COVID has put mental health, not just of our patients and families, much more central, but also of ourselves, and that people for the first time are showing, when doctors are notoriously tough and, you know, get on with it and don't show any issues with regards to how they feel. And this COVID-19 has completely taken that shine away, and we've realized that we're all vulnerable. People have been seen crying in the corners of their intensive care units or A&E departments. And thankfully, that has meant that we're all now focusing in on this in a much more generic way, as well as in a focused way within paediatrics. I think within paediatrics, we've always had a stronger emphasis on not just mental health and mental well-being, but that flexibility, because these two are incredibly related and interdependent. We've had a workforce that has needed more flexibility because of the large feminization of the specialty. And therefore, we are now looking at it and thinking, wow, you know, we had that right, and we need to get it more right. And we need to, as Dal's saying, focus on it more. But I think we started off thinking it was important, and only to find out that it was very important. So it was a bit of both. Yes, we knew it was going to be there. And yet this is also completely emphasized that was the right approach.
Yes, and I just sort of reflecting that it's quite tempting to try and solve the problems within paediatrics. But of course, we can't just solve it within our college. We need to integrate with other sort of other areas. And thinking then to you again, Nick, whether you see the contribution of other support services as crucial in terms of how you adopt different models of care, and, you know, particularly things like third sector colleagues that can come in as part of the workforce, and how do we integrate sort of charities, private companies, and those sort of things? Should we, or and if so, how?
So I think one of the things we need to think about on an integrated care system basis is children's alliances. So talking to our colleagues in the third sector, talking to our colleagues in social care and education, and having a group of people together who all have the ability to influence and change the health for our children. So a really good example is the asthma tiered approach just come out from NHS England. So working through tiers 1 to 5, looking at what can education do, what can social care do, what does the third sector do? You know, how do we make sure that all the parents and families are within this? So you have to have that alliance approach where everyone's pulling in the same direction and not against each other.
Yes, and there was another question which I'll sort of perhaps wrap up our session. One of the questions was about, you know, how do we train the trainees to be able to integrate with things like primary care, schools, and that sort of thing. And I think as somebody who's been responsible for setting training in the curriculum, I think it's very difficult to promise things like there will be more training in public health and mental health if the models of care don't exist. And I think that would be the real challenge, won't it? If you don't have that thought of how you make that patient encounter work, if that's not there, then we'll still operate in silos, won't we? So I think
exactly, that is true. And there are obviously little silos of excellence where work with primary care is far further developed than where it is in other areas. And then training can follow, but it's not yet a generalizable model or something that we can incorporate in training. But I think we can improve on it on a gentler level. It's too much detail to go into here, but there are ways of incorporating mental health training and primary care training in our own training program without necessarily taking trainees into posts in mental health or in primary care. But yes, it is not possible to make it a mandatory aspect or promise it as a definite aspect at the moment.
Yeah, and I think that's a useful plug. I'm going to take that as a plug for our paediatrician of the future, delivering really good training document, which is how we can try and train in these important, integrated aspects of care without necessarily putting people in an integrated
I
post.
think so.
Well, thank you very much. Thank you very much, Nicola, for your presentation, and Judith for yours. And thanks very much, Dal, for your contribution as well. And good luck with your in your role as Officer for Retention. And I hope this is the first steps for leading how we can improve models of care and how we can improve our working lives. And so I'd like to hand back to our President, Prof. Russell Viner. Russell.
Thanks, David. And good morning again. I think it's still morning. It's good to see again so many of you have stuck with us as we've been through many of the findings from Paediatrics 2040. Thank you to all of the chairs and the presenters. I think that our brilliant Paediatric 2040 team have given you a real lovely snapshot of the key findings, the work we've done, and actually the discussion in the Q&As has been really illuminating. It's, I think in one sense, reassured me that much of the work has been landing in the right place. It's getting you excited. It's getting your interest up. There's been some interesting challenges back from many of you in the audience, which we really appreciate. And I just wanted to emphasize that this is, in some senses, not a dead document that we do, here's the vision of the future, great, let's put that on the shelf and move on. This will be, we hope, I'm not saying a living document, but a living idea that certainly those who lead the college in the future, we'll come to that in 1 second, will keep coming back to over the next 3-5 years and thinking about potentially updating, but making sure that these ideas and your challenges are something that continue to inform us. So I think that brings us on to the final session of the day, which is really about the next steps, which says essentially, okay, given all that, what next? And that's got to be the key for undertaking a big project such as Paediatrics 2040. We've looked at the burden, what children will be suffering from, what will be affecting them, children, young people. We've very much heard cloudly from our children and young people themselves, what are the things that concern them. We've had a very nice elucidation of the innovation challenges that are going to come over the next little while. Some things that are just pent-up change, as Damian said, but also things that will really change the way we operate. We've had a really useful look at the kinds of models of care that will be different, how we'll be working, what the college might do. But now we need to think, okay, how does the college take this forward? How does the college use this document and think about it longer term? As I said, I think I said at the beginning, and if I didn't, I'll say it again now. In one sense, this is our plan for 2040, but we absolutely knew when we started this project that many of the things we came up with wouldn't need to be done in 2040. They'll need to be done in 2021 and 22. That's because as soon as you see them, they have to be things that we start to fix. We can't go, yeah, we'll fix that in 10 years. The second thing is our vision, is limited in scope. This will be out of date in 10 years, definitely, hopefully not in 5. But the time to act actually is now. It's a trajectory thing in lots of ways. If we need to shift our trajectory to hit the right place in 2040, we need much smaller shifts if we make the changes now than if we continue on our current trajectory and then try and do a massive handbrake turn in 2039. Anyway, for this session, we have exactly the 2 right people to talk to us. We have Camilla Kingdon, who, as you know, is our president-elect, and I'm hugely pleased that I will have such a brilliant, clever, innovative, and warm and human successor. We can't choose our successors, but as I said, I'm so glad that Camilla is going to be in that spot. So Camilla is going to be starting this conversation, but also with Jo Revill. And Jo Revill, for many of you will know Jo, but those who don't, is our chief exec. And we have a complex structure in the college here, a president, a chair of our board of trustees, but very much the engine room of the college, of course, is our staff. And that's hugely ably led by Jo, who, as I said, is very much involved in helping us deliver the strategy that council said. So Camilla, I think you're going to start off, and then to Jo. Please continue to put questions in the Q&A. We will come back at 12 for a final Q&A to wrap up the session. Camilla.
Thank you, Russell, very much indeed. Right, let me just do the technical bit. Share screen, sorry. I'm hoping that's going to allow me to see my slides. Apologies, give me a second.
Is it not sharing?
It's not sharing at the moment, but
okay.
Unshare and share again. See what happens.
If not, Camilla, I think Alison has a set of the slides, so if there's a technical hitch, you can always go over.
I'm hoping that's going to do the trick.
Perfect.
Sorry about that.
Perfect.
Right. I failed on the first task, didn't I? But what a privilege to be in the wrap-up session after the last couple of hours, just listening to so many ideas, so many really important questions, so much inspiration. And I think, Russell was very brave back in 2018 when he took over as president to initiate this project, because who could have envisaged how it was going to land, and how on earth could we have anticipated what the future held? And I think what Jo and I are going to do is really just kind of think a little bit about how we are going to take this forward, so that this brilliant work is really embedded into our activities going forward. I think that some of the most consistent truths about human beings is that disasters often shape the course of history and produce some of our greatest works of art, our most inspiring music, some of our most extraordinary inventions and innovations. They've all come often triggered at times of crisis. And I'm completely convinced that the tragedy and the disaster of the coronavirus global pandemic will be a defining moment in history. We've got a lot to mourn and reflect on, but we also have lots to be enthralled about and optimistic about when we look at some of the extraordinary acts of kindness that we've seen, the exciting and innovative ideas that are now surrounding us, scientific breakthroughs that are hopefully going to get us out of this pandemic, and so much more. So there's lots and lots to be really optimistic about. But to bring it back to thinking about the college, a really insightful person said to me literally last week, someone from not medical outside the college said, I find it rather strange that you can have a college where the strategic direction can change significantly every 3 years as a new president is elected. And of course, it's an excellent question, and she's technically correct. I mean, it would be awful to imagine that we could literally redirect the Titanic every 3 years. So I want to stand here today and reassure you that isn't going to happen when I take over from Russell in May. And that isn't just because I respect him and because I count him as a friend, both of which I do, but because this compelling roadmap that has been laid out in this Paediatrics 2040 report just makes too much good sense and is so clearly giving us the direction of travel that it would just be foolish to throw it away and say, no, we're going to go off and do something entirely different. Now, as a college, we're going to be setting our strategy very soon, working with a number of different members. And that strategy will be the 2021 to 2024 strategy. And I'm absolutely certain that many of the themes that have been flagged up in the workstream work are going to make a massive impact and of course have a huge. I'm going to stop there and ask Jo to take over, and then I'll come back in at the end to finish up. Thanks, Jo.
Thank you very much, Camilla. Thank you, and welcome to everyone. This is an extraordinary meeting. We're getting so many good ideas from it. So we produced an impact report at the end of last year because we thought it was important that we somehow could collect and then reflect on what we've gone through. And I think it's fair to say it's the biggest challenge the college has ever faced. The responding to the pandemic, supporting our 20,000 members through this period, and really trying to ensure that children and young people can voice their experiences and that we looked every day, every week, what they might need as that pandemic developed. So it was the most extraordinary challenge for us. I'm pleased to say that we actually kept most of our services and activities running as usual. The big challenge, obviously, is that we had to go remote overnight. So all of our content had to be transferred into digital forms. That was an exceptional challenge in many, many areas. But I'm pleased to say, I think that we did meet that. And we had huge support from not just the 170 staff in the college, but the 3,000 member volunteers who work with us every week across the different areas of the college. There were things that we did for the first time. Obviously, we had an open letter last summer, which more than 2,500 of you signed, which was to encourage schools reopening because of the huge impact that we were seeing and continue to see on children and young people. We had an expert reference group that met very regularly to help guide us through this and to do some future scoping work as well, which became, I would say, completely critical to us getting through this period. The next slide, please, Camilla.
Jo, can I think your sound is rather muffled. Apologies.
Oh, sorry.
That's better.
Is that better?
Yes.
I'm so sorry. Okay, so this year we did achieve things that I think we couldn't remotely have known before we went into the pandemic situation as to how we'd come through it. And to use the Titanic analogy, were there icebergs that we were going to hit, or were we going to be able to sail around them? I'm pleased that we did keep the vast bulk of our normal activity and business running. And that, of course, included the examinations work and the training work. So that was critically important for us. We had events and conferences that turned into remote events and conferences. And we will need a bit of time before we fully know the impact of COVID on us, I think. But now we have a recovery plan, which is aimed at looking at how we restore the services that were paused, or where we really need to get back to face-to-face meetings, exams and events. I think everybody is obviously really missing that face-to-face contact. And being able to talk to all of you remotely today is amazing. The technology holds up, but we do miss that contact and those networking opportunities hugely. We took very early decisions last year, so we actually began planning in late January of last year how we might get through what was coming down the road. And the early decisions, I'm pleased to say, did mean that we saved money, and saving members' money means that we can continue to invest in the remote technology and the other elements that we really needed. As a group of staff, I would say that we do work extremely closely with our senior officers and with all our volunteers. So the only way any college is going to get through something like this is by making sure that there really is full collaboration. And we relied hugely on the time and thought, the diligence of our members to help us, both members in the UK and obviously our members abroad too, who were critical to this. We have gone digital in areas which it might have taken months or even years to do previously. So we are going to keep hold of the best elements of these digital platforms to enable us to expand and run more events and courses and training in the future. And of course, all our committees went remote. And actually what that meant in this period is that many members were able to join us just for a few hours for these decision-making meetings in a way that actually hadn't necessarily been possible before. So that was very good news.
Sorry, Jo, there's a few people have commented, you're still quite hard to hear, I think.
I'm so sorry, Russell. I don't know what it is.
Yeah. That's a bit, I think it's better if you're closer, thank you.
Okay, sorry, I will keep more close. Sorry about that. I hope you managed to get some of this, which is that we have a business recovery plan that's now going to set out how we restore the work that did have to be paused. In the interest of time, I'll go on to the next slide so that people can see this. So following the 3 R's model that the NHS set out, this is about resetting priorities, restoring our business as usual, and recovering sustainably. So as Camilla and Russell and Hannah and others have spoken about, the priorities for us fall into these 4 areas in the first box. The retention and well-being issue for us and for our members is really critical. So thinking about that priority in this next period, and as we go into the development of a new 3-year strategy, is absolutely fundamental. When we talk about restoring business as usual, it's enabling people to progress through their careers, ensuring that we get back to what we're able to get back to when virus allows us to do so, keeping the best of digital technology to support face-to-face activities. And I think we, like others, will move to hybrid models of activities where we incorporate both elements. The whole college actually will be moving further down this road. And recovering sustainably is about ensuring that we're financially sustainable for the future, that we invest in the areas, including technology, that we need to be able to support all members as much as possible, that we run safely, we're a charity and have charitable purpose and mission, and that we rebuild so that we can ensure that we deliver what members need and what children and young people need in a future that holds many, many challenges. Thank you, Camilla.
Thank you, Jo, very much. So to wrap up this part of the session before we go into our final Q&A, I want to give you a glimpse, I suppose, of how we're actually going to use the Paediatrics 2040 report to move into particularly the next 3 years. Because as Russell said, we can't wait until 2039 to start focusing our minds and efforts on this. And I think one of the clearest messages from the pandemic is that returning to the pre-pandemic status quo is simply not an option. And I think this is true both for our workforce and for child health. And so we are very much going to need to focus on our dual goals as a college, thinking about and developing a strategy that is around focusing, as Dal and Nick and Judith spoke just in the last session, about how we produce a framework for whole career paths, so that from medical student through to beyond retirement, we have a paediatric workforce that is healthy, resilient, and flourishing. And that isn't going to be just about paediatricians. We're going to have to think much more widely around the broader healthcare workforce. The other side of our goals are clearly very, very pressing, and that's around child health. And the question that I think we need to ask ourselves is, how do we make children a priority in the country that we live in? Because I think many people would suggest that the last year has taught us that the priorities of children have slipped out of the out of radar. So how do we redress that balance? How do we move forward to make sure that the rise in mental health that we've heard a lot about this morning, the worsening levels of deprivation that existed before, but now as a result of the economic harm of the pandemic are significantly worse. We've got some very significant challenges ahead of us. That sounds very daunting, possibly even a bit gloomy, but I think this gives us a huge opportunity, but a huge opportunity to make a difference to us as a group of professionals, but thinking much more widely around the people that look after children in this country. And I'm absolutely convinced, Venkat's been talking about all of his ideas in one of the earlier sessions. There are going to be all sorts of innovations and ideas, both within tech, but also within support and careers work and training and so many other ideas, service innovations and transformations, working with our other partners in other specialties and also beyond medicine. So lots and lots of exciting opportunities going forward. Now, we haven't got a lot of time left, but just two things I wanted to flag up that are, I think, going to be absolutely core to what we do and have already started doing. And that's firstly our equality, diversity and inclusion work. This really came crystallized in our thinking last year. We've got a huge number of members, over 20 members are now working on these four work streams. Really looking at how we can do this in a really meaningful way. And so, for instance, some of you may have noticed earlier, the closed captions weren't switched on for this event. And one of our members flagged it up. And I can only say I'm really sorry about that, because actually this is the sort of thing that we absolutely want to get right. So I think, thank you, Fiz, for flagging it up. And thank you to the events team who sorted it out immediately. But, inclusion is about understanding that we're not always going to get it right. But, we want members to be brave enough to put their hands up and say, I'm really sorry, but, you need to rethink how you're doing this. and so we can have these kind of honest conversations. So, you know, today I hope is an example as much as any of how we are endeavouring to change this. The other really exciting work is around climate change. So for those of you that came to an AGM a few years ago, or it might have even been a year ago, time goes so fast, but climate change was brought to us as a pressing and urgent issue for the college. And of course, there was no argument about that. And so we have really worked at speed to develop 5 really challenging work streams. And we've got over 40 members supporting us with this work. So you're going to hear lots more about this. We've got COP26 happening in November, and we're really using that as a focus to kind of get cracking. So loads and loads of exciting things happening. We want you to get involved. You know, that the work that Russell's started in 2018, it's got to stay live and dynamic, and we can only do that with member involvement. So keep an eye on the website, come and join us at our conference in June. It's going to be virtual, but we've got an absolutely sensational programme over 3 days from the 15th to the 17th of June, loads of opportunities to network, join small groups, but also some really terrific plenary sessions. So please get involved. If you see things that you don't feel are right, come and help us change them. We want to get into a kind of much more dynamic way of working, and really kind of, you know, Paediatrics 2040 has shown us what engaged members can do in terms of setting the tone and the path for going forward. So we've heard lots of thanks already. I want to thank Russell for really bravely starting this work in 2018 and making sure that it was completed, because, you know, boy has he been busy, and in fact everybody's been busy. So actually trying to keep people on task and making it happen, particularly in the context of a pandemic, has been hugely challenging. And the fact that we can stand here today with these extraordinary reports is just amazing. So a massive thank you, Russell, and a huge thank you to all the workstream leads and all the people who contributed. And of course, a huge thank you to Alison. You'll be pleased to know Alison's going to be working on our climate change project. And, you know, having seen what she's done with this, I'm just so thrilled, because I think you're going to see great stuff on climate change, because Alison has a fantastic knack for getting things done. So thank you all very much. Back to you, Russell.
Thank you, Camilla. Huge thanks. And Jo is back with us. We're hopefully with the mic that's working slightly better, because normally it works very, very well. So thank you, Jo, and thank you, Camilla. Again, inspiring words at the end, and a real commitment to take the key principles and the key aims forward. We've got about 7 minutes for questions before we finish. So please put questions in the chat if you have any. There was a couple of questions already in the chat, some of them more specific. I think to pull a theme out, one of the questions was, how does the college influence moving forward in this really complex world? There's a specific question about how we work with PHE, but of course PHE won't be there after September in England. And of course there are organisations public health organisations in other devolved nations. How do we build our influence moving forward around children? I don't know, Camilla, if you have thoughts on that. I would say, you know, having done 3 years in this job, that ain't easy. In fact, the president probably spends all of their time, you know, knocking on doors, tapping on shoulders, ringing people up, trying to influence. Are there new ways we should work?
I mean, it's interesting.
Oh, have we lost Camilla for a moment? Nope, she's back.
I'm back. Sorry, don't know what happened there.
That's right.
What I was saying was I'm in the process of doing my induction at the moment, which actually has been fantastic. But what it's meant is that the team at the college have set me up with a whole lot of opportunities to meet people. And the most extraordinary unifying impression I get from all of this is just how interested people are in children, how committed they are to supporting us in our work. So, you know, whether you're talking to pathologists or physicians or people outside the Royal Colleges, I think people understand that, particularly as a result of COVID, children, there's a real kind of anxiety, isn't there, about children and the impact on children. So I think we've got a real opportunity at the moment to kind of capitalize on that, and keep that kind of message going. And I think, you know, you've set that agenda very clearly in your presidency. And I think particularly in the last year, in some of the ways we've advocated, be it around free school meals or flagging up the other kind of consequences of the pandemic on children. And I think we just have to keep that up. But, you know, I was really empowered listening to the children at the beginning and some of their insights and messages. It's about, if we, you know, they're our guiding light, aren't they? So I think it's also about doing a lot of listening.
Absolutely. Jo, did you have thoughts about, how medical Royal Colleges, and us in particular, grow our influence in this modern world?
I think it's really interesting, Russell. Can you hear me more clearly now?
Yes.
Good.
Not perfect. Yes.
Sorry about my sound quality, everybody, earlier. I think most public generally don't know what a medical Royal College really does, and obviously have no connection with the medical Royal College. So I think how colleges grow their influence is by demonstrating impact, but also speaking to their mission. And sometimes I think colleges get slightly lost along the way by focusing on specific activities and not talking about their core purpose, and not being clear that they are there representing the breadth of their membership. It's a crowded area, isn't it? And right now everybody wants to talk about pandemic and health and, for us, impact on children and young people. So I think what we've tried to do in this period is be really focused on the areas where we think it is essential for us to talk and speak out and advocate. We cannot advocate on everything. It's being really clear on the areas where we bring most benefit and most purpose. But I think for the colleges coming out of the pandemic at some point and restoring activities and working with the NHS to get things right, it's really essential that the collaboration that has actually happened between many of the colleges during this period continues, and that people see that collaboration, that they understand what the purpose is of the work.
Yeah. Thank you. Excellent. Can I ask both of you another question, which is about international? Our colleagues put a number of comments in the chat, but Paediatrics 2040 was very purposely about the UK. But of course, much of the work around innovation, around change in burden, around all of it, actually is hugely applicable across the world. What are our ambitions? Shall we go back to Camilla and then back to Jo?
Thanks, Russell. You know, it was before Christmas. I think we were on one of our COVID expert reference group calls, and Andy Pollard was, talking about his incredible journey with the vaccine. And he said then, and I found this a very compelling question, he said, how can we make sure that everything we've learned in this year translates into improving child health globally? And I've really taken that to heart, because although I know, this country's been devastated by COVID, we have learned a lot, and we have a resilience that will mean we will recover. But, there are going to be parts of the world that are going to be devastated for a very long time by this, and were devastated before. So I think our responsibility internationally is significant. We know that 20% of our membership live outside the UK, and we have an absolute commitment to them too. In fact, next weekend is our first international conference with our colleagues based in Singapore, but essentially in the kind of whole Southeast Asia Pacific area. And actually, having chaired that conference committee, the engagement, the ideas, the energy, and the really touching loyalty to the Royal College is just incredible. So we've got some great friends internationally. And so I think, exciting and huge opportunities, and something that, I think we can do a lot more with.
Brilliant, thanks. And Jo, final comments from you.
Thank you, Russell. And we know that during this period, members from actually across 67 countries have been accessing our documents related to the pandemic, whether it's the guidance on running services, the clinical guidance, the work that the children and young people have done. So we feel that we have had that global reach during this period. The question for us always is, what more can we do for our international members? I was on a membership ceremony yesterday with David Evans, where we admitted fellows and members to the college from right across the world, and hearing the stories of the work they're doing and actually the innovation that is happening in these countries is really inspirational. And I think one of my jobs is to talk to the staff and make sure that we collect their examples of innovation.
Well, look, we're at time, so thank you both. Thank you, Jo. Thank you, Camilla, for a really, again, another engaging and inspiring session. And particular thanks to all of our speakers and chairs and all of you who have attended today, because this is about you. This project needs to be so much more than a report. It needs to be read, built on, worked on, and implemented. And I have huge confidence after today that we are absolutely on track to do that. The Paediatrics 2040 project has been very important to me during my time as president. But one of the important things, the most important thing, I think, is that I found that everyone who's worked on it with us has added to it and taken it far beyond what those of us who originally set it up thought it might be. It's very much taken on a life of its own. People have taken ownership of it, and that's exactly what it needs to be. So thank you all. Today has been recorded, so if you wanted to watch it again, but also if you wanted to tell your colleagues about it, it'll be available to watch. Please go and visit the microsite. You've had the URL before, I'm sure. I can't quite remember what it is now, but all of the data, the talks and all of the reports are on the microsite, and that will be a living microsite. Thank you again, particularly to Alison for organising this extraordinary whole project, and all of the college teams and members who have assisted with that. So thank you again. I think this may be one of the last things I do as president, and that will be sad for me, but obviously you have a much more enjoyable future to look forward to with Camilla. But thank you so much for attending today, and have a good rest of the day. Cheers and goodbye.